presentation that we're presenting today is called The Art of Effective Feedback, a Prescription for Success. We're giving unlimited refills to everyone. So my name is Raul, for those of you who don't know me.
Kristen. Nancy. Thanks for coming today. It's our last workshop. I just wanted to orientate you guys to what's on your desk. So we gave you guys a purple package with all our handouts in it. On one side you'll see our workshop handout, as well as the outline, as well as our slides. And then on the other side you'll see the feedback form, so one individually for all of us and then one final one. If you guys haven't put your names on your name tag, or if you have your own name tag, if you could just put it out front, there's markers scattered around. We also have a playing card for everyone. Oh, Annika, you don't have one. Maybe I'll give you one. And this is how you guys will be divided into groups later on. You should have an eye clicker, and you should also have a set of cards with rings. So if you guys are missing any of it, please speak now.
I'll get them back in.
Right. Everyone has everything, right? Okay, so our first icebreaker activity. I don't know if anyone watches What Not to Wear. Anyone watches it?
Any cheers in the audience?
Just watch it, but
I have my children. I needed to eat it.
So this is an outfit that I
Yes,
go
dear.
run errands in, and I wear all the time. I think it looks fine. Like, you're running errands. Like, I don't care.
Okay, so here's what I think, aside from all the holes, meaning that there's a lot less fabric here in general. I feel like this is an invisibility cloak for you.
I feel like it's just comfortable and it's me, and I don't know. I don't have to worry about anything in it.
Do you feel like this comfort level, right, that you feel in this, is a little bit of a rebellious response to having that other side of you, which is like, you know, the one who has to get dressed up and get your legs tan and, you know, things that feel like effort.
I found that people, their perception is that I am that girl from American Pie.
Right.
And I'm not. So then you go way the opposite way to be like, no, that's not me, and quit saying that it is.
So this is a compensation, in a way.
This is me, and I rebelled even more when people say it's not me, because it is, and they don't believe me.
Right.
All right, so now that we're all adults, we can sort of come to the realization that rebellion isn't necessarily something that works in our favor sometimes.
Yeah.
Well, are you open to us showing you other ways of, you know, showing who you are? Casually.
I'm open to hearing it. I'm curious to see where it goes.
This isn't about a complete overhaul as much as it is about refinement.
Except for this tube wrap.
Yeah, and the jeans.
Oh, and the
jeans. Yeah, okay.
And the sneakers.
Come with us here.
I want to see you in this outfit.
So we just wanted, as our icebreaker activity, for you guys to pair up with the person next to you and to utilize some of the skills that the first workshop taught us in giving feedback, and we want you to have some fun with it before we start. And we're going to give you some photos of celebrities, and if you could brainstorm some feedback you would give the celebrity in terms of his or her fashion sense. And you'll have 5 minutes, and then if your pair could come up here, and then you have 1 minute to present. It doesn't have to be what Stacey and Clinton did, but something like a commentator on eTalk or What Not to Wear in terms of a critique on his or her fashion. Does that make sense? Any questions? Okay. I think we have. Are you two in the pair? I think I'm a little confused. Yeah, 5 minutes. Oh, Sally. Dr. Gatti, did you want to participate as well? Yeah. No? Okay. Okay. Sally, I think you missed the maybe you want to clear up. one.
So this is.
Okay, yeah. Oh,
No, I'm not.
Let's do it.
So you got a hands up one.
I didn't want to give you guys too much of a racy. Keep it appropriate.
Yes.
Okay.
Would you wear this? He wasn't on that.
I did not impress with Lady Gaga. Yeah, exactly. Birthday is, sort of one of my thoughts, definitely
And or like the
still,
like it might be right.
yes, that's actually not quite so bad for what you and we also just.
I like the parrots. It's very trendy. The way it's done. Kind of have that like he's trying to just trying to go for the edge of like.
Yeah.
Closure.
Seems to be done. Yeah. Exactly.
How are you guys doing? Matthew and Nats are here.
I'm wondering how you can have it so long.
The guys are good critics.
You guys are just to the point. Okay, so given that most people are done, we're gonna start our presentations. Do you boys want to go first since you're done, or do you want to, would you like to see an example?
No, we can give it a try. So,
You guys want to come up here?
we had this well-known young lady.
Oh yeah.
She's famous for being the daughter of a hotel billionaire. She's wearing nice matching accessories, mostly in black ribbon, purse and shoes, and she's dressed appropriately, so she has this tendency to sometimes show too much skin, but this seems fine. Yet still feminine and somewhat classy. It looks like a bee, so it's and could be for Halloween. And I guess she probably knows better than Nasser and I what she can do.
I mean, good, 52 seconds.
Very specific, very concrete examples. I think that was a great feedback.
And we were trying to figure out based on the other attire if this was Halloween, because to me that would have made a difference.
We don't know.
Yeah.
Does another group want to go? Oh, depending on what it is.
Yeah, we can go.
My
They have Jared to lead it.
Yeah.
Jared Leto. Jared Leto. He's an actor.
Sally needs enough time.
So I think to practice this basic would be back to be different from culture to culture, from my culture and different from their culture. Also from gender, because I'm a man and they're girl, so it will be different here. From even inside my culture, there is different culture. From culture that I look is inappropriate clothes, looks translucent and tight. Also what he wears sometimes. Standing, I like the standing, but not standing. How he's looking to the camera, he's exactly like me. I think yeah, he's doing something that to the photographic maybe, I don't know, but how is he wearing the clothes? From the color point, I think that's okay. I don't know why he's putting the jacket there. That's from my point, from my question.
So we like the shoes. We like that he's trying to go for almost. I like that he's trying to go for like an edgy look, but he has a gothic component to him. He's wearing black nail polish. I do not like. If you can see closely, he has black nail polish on. You see it? Yeah, right there.
Blends with the pants.
It's different.
Time's up.
So what I really liked about Saleh is that he kind of gave that everyone can have their own perspective, and you may bring in your own experiences in giving feedback.
Yeah.
So I think that's important to consider when giving feedback.
And
Next
Melanie
group.
was very specific.
Yes.
Gave specific details.
So we have
Next group?
We have Miley Cyrus. So, Miley today is actually looking pretty good in the sense that all of her private bits are covered up this time. So that's definitely an improvement compared to some of the other pictures that we've seen. We like that she's going for this athletic look. We think that's a good look for her. But there are some ways that we would suggest perhaps improvement if she were to come to us for fashion advice. Right. So given that she's probably going for the athletic look, like we said, we thought that she probably could find a more comfortable and practical running top that would suit her fitting and suit her style. We thought that if she is going to be out running and exercising, perhaps a hat or a band would give her to sweat. And her pants are a little bit too long. She will show a little down. She might trip on them when she's running. So there's a lot of other practical options that would suit her style and body.
Right, exactly a minute. You guys, it's actually interesting because you guys used a model that we'll talk about, but probably without knowing it, where she should keep on doing something and perhaps change the method she's doing. It sort of relates to a model that we'll talk about later in our talk.
So I really like that addition of the suggestions for improvement.
And lastly, you guys have.
So we decided that we were going to give her feedback using the sandwich model because we felt color coordination was like a sandwich. We thought it would be appropriate. So starting with her tights, we felt they were very true to her personality. It's a pop of color, it's bright, it's bold. So we like that.
And about her dress, we felt that the print was bold and we liked the colors, but we felt that if the dress was a different cut, which it might help flatten her figure more.
And coming back to the top of the sandwich, we thought the lipstick was, again, a great combination with her tights and kind of carried the theme of the fuchsia all the way through. So we liked it.
So basically, she could keep the color combinations, but just work on the dress to a more flattering.
Exactly right as well.
So I like that you used the sandwich model in a way that didn't focus on, it was a unifying theme. It wasn't that the positives were purely superficial and the negatives were more deep. They were all along the same theme.
Yes, there was not much depth.
That's true. It was what we were looking for. Anyway, so for welcome Jean. So for those of you who just came in, we were just doing an icebreaker where we were giving using our feedback skills that we learned from the first group to give fashion critique to celebrities that are well known. And I think you guys utilized a lot of the skills that were taught last time, and hopefully we could expand on that during this workshop. And we just wanted to start off with something fun to show that feedback is not just in the classroom setting, it could really be applied to life, and that there's many different perspectives to feedback. So now we are just going to give you guys an outline
So just a big bird's eye view of what our talk will be, our workshop will be about today. We're going to start with getting to know our audience, so we'll be using our eye clickers for a pre-test. We're going to set our own personal objectives, which I think are all great adult learners. Then we're going to go into the importance of feedback. We'll discuss some strategies for providing effective feedback to our learners. We're going to discuss what's meant by the idea of the student-centered feedback approach. We're going to have a break. There's great refreshments. Help yourself as we go through. After the break, we're going to come back. We're going to focus on skills and really building great feedback skills to build on our previous workshop that we worked on. And one model that we seem to really like is called a 1-minute preceptor model. So we're going to show off our talents and role playing, and everyone's going to have a great time. And we're going to increase, and then we're going to go into increasing receptivity to feedback. How can we get our learners to be more receptive for asking for feedback and implementing that feedback? And we're going to conclude with a wrap up and evaluation. So our objectives, we kind of broke it up into 3 parts. So again, our knowledge, skills, and attitude. Nancy will be taking the lead on the knowledge component, really describing some of the theories and principles around feedback that won't be novel to many of us. I'll be going over some of the skills, again, focusing on strategies and tools we can use that are time efficient and effective, especially in our busy practices. And Kristen will be focusing on increasing learner receptivity to feedback. So again, I know we went through the packages, just want to make sure that everyone's oriented again. So on the right side, we have our personal feedback forms and the workshop evaluation. On the left side, we're going to use our sheets now. So again, the first one's our lesson plan. The second sheet you guys can pull out, the orange one called Personalize Your Learning. So we can pull that out for the next activity. We have a role play scenario thing for after the break. And then we have our slides, we have our handout and our references at the very end. So the next activity will be on the orange sheet. It's called Personalize Your Learning. So as adult learners, we're all internally motivated to learn, based on our own learning needs. So we thought it might be interesting if we all kind of set one take-home objective that we hope to achieve. And it'll be really interesting to come back at the end of the workshop to see if you've met your personal objective. So this could be a knowledge, a skill, or attitude. If you guys don't mind taking 2 minutes just to jot down maybe one objective you guys hope to achieve.
So about 25% of you guys are done. 1 minute's up. If you want to revisit that at the break, you can. So the next part of our presentation, we just want to get a sense of your comfort with giving and receiving feedback and how often you're involved in giving and receiving feedback, just to get a sense of the audience that we're dealing with. So time to use the eye clickers. So I'm going to preface this by showing you where the on-off button is, because I'm the notorious person who doesn't turn my eye clicker on. So if you could just ensure that the blue light is on. Okay. So the first question, also your color cards, the A, B, C, D, E, they're meant as our low-tech backup for this exercise. That's why you have those. So for the first question, play, and everybody, if you could answer if you're giving feedback on an hourly, daily, weekly, monthly, or yearly basis.
And this is any kind of feedback to anybody or specifically in?
I'm thinking particularly in medical education.
Not so much fashion.
Daily. And it has to be to their face.
Can you change it? Or no?
Melanie's asking what she would change it.
Once you've submitted it, not that I'm aware of, and we're just waiting for, so we have 1, 2,
You can charge both sides.
9, 10, 11 responses. One more, perfect. So we're just going to stop this. And graph. So most of you are either giving feedback on a daily or weekly basis. you an hourly and monthly. Perfect. I don't want to put that person on the spot, but if they want to volunteer, is anybody giving feedback on an hourly basis? That's okay, you don't have to say that. Okay. Question 2, how comfortable are you with giving feedback? And we'll collect responses now.
Interesting. Okay.
Excellent.
So this is encouraging for us because hopefully by the end of the presentation, most of you will be responding A, and we do have some room for improvement.
Change your answer.
Yeah, you can change it.
Oh, you can change it.
Oh, you could change it. Okay, great.
Oh, yeah.
Thank you for demonstrating that.
Lifelong learning.
And question 3,
That's me.
how often do you request feedback?
Oh.
There's no it depends in there.
We'll take that feedback in consideration next time we design this. And final, perfect. So as we kind of expected, you're probably less comfortable or less frequently requesting feedback for yourself than you are in the habit of giving feedback. And this is one of the things that we want to address later on in terms of how you're creating a culture of feedback seekers as well as becoming a feedback seeker yourself. And the final question, how comfortable are you with requesting feedback? So it's interesting because it seems like you're more comfortable than you're actually, than is actually reflecting the frequency that you're asking for feedback. So we might want to kind of reflect on the barriers that are preventing us from asking if we are somewhat comfortable to do so. So that ends this portion of the icebreaker.
And everyone should turn their eye clickers
Off
off
now.
to save batteries, but we will use it again later on.
I would just say that for that last question, because it's how comfortable are you requesting it? So just the process of going up and asking them. So I would say in that sense, very comfortable, but then if there was another question, like how comfortable are you as you are receiving the feedback? I think that would be a different answer.
If we repeated that question after?
Yeah, just because I don't like, for me personally, like I have no problem asking somebody for feedback, especially when I'm in the process of giving it to them as well, if it's like an exchange. But then sometimes hearing the feedback is not the most comfortable thing.
Right. That's a good point.
The other thing why I see previous question, why I asked it depends is I'm asking more feedback on something that is new to me, like as opposed to if I just do my regular clinical job with the cellular team, I'm not gonna ask them every day how am I doing for years. Just doesn't make sense.
That's a good point,
right?
Matthew. We actually talked about that in a few slides, so it's almost as if you.
Thank you for the segue.
It's the beauty of adult education.
Any other comments? So just to start off our didactic section, I'm going to talk about why we care so much about this topic and why feedback is important. So our group went through quite a few different texts and references, and this is the definition of feedback that we compiled. So we believe that feedback is information that students are given about their performance, and this is compared to a standard. And this is with the intention of guiding them in acquiring desired knowledge, attitudes, and skills. So why do we care about feedback? So we often don't see ourselves as others see us. And I think we demonstrated that, for fun, with the icebreaker activity, where, maybe in our fashion sense, we're not perceived the way that we think we are. And this could be something from the sound of our own voice and our mannerisms when we watch ourselves on video. I think we've all had that shot. And this is especially important, as Matthew pointed out, when learning a new skill. At that point, you don't really know what you know and what you don't know, and you really need constructive and supportive feedback to make progress. This is a slide that we referenced from Dr. Batty's lecture from Teaching and Learning Part A. And this is what she drew from a paper from Dunning in 1999. And I think it's quite classic, so I wanted to go over it. So over here on the x-axis is the level of competence of learners. So low competence learners, average competence, and high competence. And on the y-axis here is the ability to self-assess. And what's interesting, some of you might have already seen this, but what's interesting is the average competence learner, for most people, they're pretty good at self-assessment. However, the lower competence learners tend to have poor self-assessment skills in the sense that they tend to overestimate their ability. And the higher competence group, surprisingly, also has some skills in that they tend to underestimate their abilities. So I just want you guys to keep these three cohorts in mind. So I want to talk about this lower competence cohort first, because there's been quite a bit of research in this area. I just want to draw an analogy to neuroscience and neurology. I don't know if some of you who rotated through stroke unit or neurology might have come across this term anosognosia. And this is when there's Gene shaking his head. This is when there's been damage to the parietal lobe, either through stroke or trauma. And on the other side, on the contralateral side, they're actually paralyzed. But due to the nature of this illness, they actually don't know that they're paralyzed. They have no insight into their illness. And this has been drawn to this lack of metacognitive skills, which the other feedback group has introduced in their talk. And it's actually quite widespread in the feedback literature. So meta means beyond. And so metacognition is cognition about cognition, or knowing what you know and knowing what you don't know. And it's thought that this lower competence group has this lack of metacognition, or to know what they don't know. And it's this combination of poor performance and inability to recognize that poor performance that is quite the combination in this lower competence cohort. And something that we need to target when we give feedback, and I'll touch upon it in a little bit.
I think Dr. Batty had a comment.
Yeah,
Yes.
just
I'm just double checking my neuroanatomy. It's a right-sided lesion in the brain.
yeah, anosognosia, I think, is a right side. Did you say
Parietal.
that?
Right. Yeah.
I just said parietal.
Oh.
You said
Yeah, I said
parietal, but I think the
It
other
has to be
thing,
right
and
side.
this, I'll say it now, I've just read it again, it's a later comment, but this is one of these magic moments where being a clinician helps you be a teacher. Because if you have any realization that your student has had some kind of a right-sided insult any time in their life, you know, prenatal, head injury, whatever, you won't be surprised if they have this lack of insight, right? And it's the kind of thing that I expect over the next, I'll be optimistic, 20 years, you will see this get unpacked, and you will see things like people getting imaging, and by totally off the wall, but you will see it. Mark my words. We might get to the point, for example, where entry into a health professions field, you don't have to do your LSATs or whatever, right?
Just get an MRI.
You may be sending in a functional MRI, right? And smart people will be reading it and saying, oh, the right side looks a little, you know, maybe that's not, person isn't at the top of our list. And I'm not being facetious. I mean, that's becoming our scientific knowledge base. And it's the kind of area where our collective, because I need help from other people on this one, our collective understanding of neuroanatomy and neuroscience actually helps us in education.
Good point. Thanks, Dr. Batty. Just moving on to the higher competence cohort, there's not as much research in this area, but their ability, their way of decreasing their own ability, or thinking that they have decreased ability, it has been termed the false consensus effect. And that's basically where they think because they do so well, they think everyone else does very well. And so they tend to underestimate their comparative abilities as compared to their peers, but they're actually quite good at estimating their absolute abilities. And I just wanted to talk about this study that was done by Kruger et al. A few years ago that I think is quite interesting and that I think demonstrates these cohorts quite well. So what he did was he sampled about 200 undergrad students and he had them write a test. And then right after the test, he asked them how they thought they did in terms of marks on that test. And then he compared that to their actual marks, so their perceived marks to their actual marks. So on the x-axis here is how well they actually did on the test, with bottom quartile, second, third, and top. And this is the actual percentage mark. This light gray line here is the actual mark. So people who did poorly at 10%, people who did well about 80%. And the black line here is the perceived mark. So as you can see, the bottom quartile, they overestimated their ability by quite an astonishing amount. People in the middle here were pretty good at self-assessment. And people at the top here underestimated their abilities, not by as much of a gap, but they still did. I thought it was quite interesting. It's been reproduced in a number of areas, not just in marks, but in your social abilities and humor. It's quite widespread. So it's quite the phenomenon that's reproducible, and I think it's quite interesting. So just going back to this normal curve concept of the low, average, and high competence cohort, the lower competence cohort here has lack of metacognitive skills, inability to know what they know and know what they don't know. So we know that by increasing their competence and increasing their knowledge, we can actually increase their metacognitive skills. So hopefully by giving them the appropriate feedback to increase their knowledge and to reflect and to self-assess, we can move them over here. Over here in the average cohort, these students are pretty good at self-assessment. This is sort of the majority of our learners. And the importance of feedback here is to help them further improve in their competence ability and to continue to self-assess. And finally, the higher competence cohort here who underestimate their abilities. Our feedback here should be reinforcing what they're doing correctly, reinforcing good behavior, and making sure that they don't burn out. Yes, Eugene?
So based on this, I mean, are there studies that actually look at, how we're able to move the curve based on, strategies that we use, or?
Yeah, it's a good question.
Okay.
I was actually going to talk about a study in the next slide, and in terms of strategies that we use, that will be later on.
Okay.
We'll talk about specific strategies. Stay tuned.
That captured your attention.
Well, I'm just thinking that, probably, it may be an assumption that in a group like this with many physicians, I wonder if there's a greater proportion of people on the burnout side versus the other side, and certainly as people that are, at least for most of us, that are teaching future physicians, I mean, I think we're often on that right side of the group trying to manage burnout, actually. It's actually a very difficult skill when.
That's a good point.
So what did I tell you the first day of the course?
Aim to pass?
Aim to pass.
That's your feedback. You did it.
Go with the flow.
I know, I think this is your first course. It'll become your mantra soon.
And it's interesting that you bring that up too, Jean, because there isn't as much, correct me if I'm wrong, Dr. Batty, but there isn't as much literature on the false consensus and on that higher cohort, unfortunately, from our literature. So our literature. So we actually, and we'll give you strategies, but unfortunately there isn't as much on that.
There is a decent literature if you use gifted as a key.
Oh, interesting.
So there are features of gifted learners that we do know about. You can ask me in the afternoon.
Okay. Just to reiterate, it's important to give feedback to change bad behaviors and sustain good behaviors, in a nutshell. There has been studies that show that feedback does change behavior, like Eugene has. I just highlight this one because it sampled physicians, and it was actually quite interesting. So it was conducted by Fiedler et al. They looked at 255 physicians. Most of them were GPs. There was a selection bias because these were volunteer physicians. But they volunteered to receive feedback from a whole variety of aspects about their practice. So they actually received feedback from their patients, from consultant colleagues that they referred to, from people who worked with them in the clinic. They received feedback on all aspects of their practice, and they looked at it. After 3 months, they completed a survey, and they asked them, how many of you contemplated change? How many of you guys initiated change? We have the reference if you want to look at it in more detail, but a good percentage of them contemplated change, and about 66% initiated change to further their practice. Of course, they didn't sample them further to see if there's any objective markers, but it does show that people do take feedback into account to improve. Again, this was probably a more motivated group because they were volunteers, but still one example of how feedback does lead to behavioral change. I just want to end off this segment with the spectrum that the other group also talked about last week, where ideally we would like to give feedback to learners to move them along from an unconsciously incompetent learner when they're first learning a new skill, so an overconfident medical student, along the spectrum to an unconsciously competent learner. And like the other group pointed out, it's that emerged doc who has this acute clinical sense where this patient is decompensating and they move them to a higher monitored setting, right? That's the unconsciously competent learner that we all aspire to be. And so just to end off the segment, we wanted to have you guys do a think, pair, share activity. So if you could take a look at your, does everyone have a playing card?
Oh.
So there are some people, so if you could find the person with the same number of the card as you, there are some extra cards. So some of you might not have a partner, but we'll hopefully try to figure that out.
Does anybody have an 8? You have an 8.
Like, go fish.
And then where's the other extra one?
Does anyone have a chat? And then the 8 and Jack.
8 and Jack can go
Melody.
together. So is your Jack?
Oh, okay.
Does everyone else have a card?
7?
Annika's going with Nasser?
So I guess name a time.
So if you guys can name a time where you change your behavior based on feedback that you received, and if you could also brainstorm some characteristics of that feedback that ultimately made you change. It could be for better or for worse. And it really could be, it doesn't have to be clinical, it could be anything. Give you guys maybe 3 or 4 minutes.
I know, I was wondering too, but I didn't kind
I know, it's hard.
About my abilities when that's not true. Not shy away.
I guess you also train to be obese research. Yeah. So do you have to learn?
So I think I tried in my mind. Yeah, no, I would go there.
That was
Yes.
because I don't know. Right.
And there's certainly more than anything
totally knew that.
So I think, I mean, my behavior,
That's okay.
Which is a skill that is
there's 1 week, there's 3 months.
It's going to be hard. Like, because of
Okay, so I think people are finishing up, and feel free to continue to grab snacks as we're talking outside the way. You guys are sitting close to it.
I felt like I was shopping for a child's lunch.
So as we were sort of circulating around the room, it's interesting to hear that some people find it sometimes harder to think about good feedback because maybe sometimes that doesn't stick out in your memory as the trauma of bad feedback. So I thought that was interesting. I just wanted to give an example of feedback that I received that was very simple and straightforward that I thought really changed my behavior. It was during residency in family medicine at McMaster, and we had these, some of you guys might know in family medicine, we have videos where our supervisors are able to directly observe our interactions with patients. I think I was at the end of my first year residency, and she noticed something very simple that was inherent to me that I didn't even realize I was doing. She said, "Nancy, you tend to cut patients off a lot." Because I'm always running late, right? So I'm looking at the time, and I would ask, "Oh, you know, what brings you to clinic?" And they would say something, and I would just cut them right off, and I'd be like, "Okay, so let's talk about this, you know, shortness of breath." And they're sort of midway through the sentence. And she said, "You know, you might think that's saving you time because you're late, but sometimes if you just give them a minute or two of uninterrupted time to just hash out their feelings and emotions, you might actually save yourself that door handle, oh, by the way, and then you have to sort of talk to them all over again." So I thought that was very effective feedback, simple, to the point, relevant, time specific. That really changed my practice. So if you guys don't mind sharing, maybe we'll start. Does anyone want to go first? Maybe we'll start here, and we'll just record what your behavioral change was and what the characteristics of the feedback was. So go ahead, Matt.
So mine was the complete opposite of yours.
Okay.
Where I was told that you need to develop skills to stop the patient discussing everything. Like, it's okay. Like, if they have 4 issues, you don't need to deal with all 4, assuming that they're not all acute. You know, make a list, like write them down as the patient's telling you, and then tell them, ask them, which of these 2 would you like to address today? And then let's go to follow-up appointment. And I think what was helpful in that situation, like I was obviously aware that this is now going to take up a lot of time, but I just didn't know how to shut it off, or even believe that it was okay to do that in a training setting. So I was thinking, is this going to look like I'm not giving the patient enough time? Am I going to get criticized for sort of interrupting the patient, as you said? But it was actually reassuring to hear that, okay, no, you do need to have some time management, and you do need to be on top of your time as well, and follow whatever your agenda is, as well as patients' development.
And what do you think were the characteristics? Oh, you said it was.
I started writing some, but if you have anything to add, that it was descriptive, it was specific.
It was specific, yes.
It's confirmed.
I think we could start. So it's something that you've kept with you and you think has really changed your practice. And so now do you limit it to 1 or 2 issues per clinic? Just
if I'm feeling like I'm being sort of pushed for time, and the others really can't wait for the issues, then I will use it.
So a couple of questions I have. When was this feedback given to you? Was it immediately after an encounter that you had gone over? Okay.
Because we were in the instance of videoing.
Oh, you had that as well.
Yeah, so it was sort of like at the end of the morning session.
Okay, thanks then.
So a couple of points of feedback that I got that kind of kept on the same thing was that when I was reviewing one of my teaching log, reviewing feedback I got from the teaching session I did, as well as from the workshop, it came up twice where a suggestion would have been to go over a quick summary or hit the highlights at the end just to kind of reinforce the teaching points. So I haven't had time to change that yet, but obviously I noticed it and I'm going to try that in the future. So I guess again the features would be that it was an easy, simple, specific thing, tangible, something I could easily achieve, and time links is right after.
Really related to clinical teaching.
Oh, that's good.
Since going to since starting a course again, since recently going back to work, I've been getting sort of a little bit more stressed out at night. I guess sort of like the night before something that happened, like a night before something will be due, or even a week before. Like last week, I was completely freaking out about the portfolio, and then I'd be fine during the day, thinking like, oh, I'm so much better than I used to be at school at like managing my time. at 11 p.m. like, oh my goodness, like there's so many other things I need to do, and then I would like whip out the computer or my phone and I'm online, and my husband's like, you're freaking yourself out like at bedtime, like how does this make sense? So the next day, he sat down with me and he's like, no, this is not sustainable. He said, you know, he's like, it's not worth all of this stress, and he's like, your deadline's not even like the next day, so he said, you know, from now on, like, let's try not looking at our computers or our phones, like, sort of within half hour to an hour before going to bed, and that no matter what it is, like, you can always wait until the next day. So this whole last week, like, I've much better at it. Like, I haven't actually been, like, 11 p.m., like, my computer's my phone, everything is off. Yeah. So yeah, so I think he was very helpful in that the timing was very good, so he wasn't trying to give me the feedback when I was like freaking out at the moment.
That's a good point.
It was very specific, and he helped me come up with a plan. And I think the language that he used was also very good because he's been in my shoes and he kind of knew what to say, sort of thinking like how would he take it if it were role.
I think that's very interesting that you're seeing feedback from, you know, someone not in the clinical setting, someone who's not in the work setting, but someone who knows you well. And I think it's always being very authentic. I think it is difficult, right, to use the appropriate language so that you don't evoke any negative emotions, right? So I think he did it very tactfully, and I think you bring up a good point. Being time specific might not be right after. It might be more appropriate to give you a few minutes, a few hours or a few days to just reflect on it yourself. I think maybe it's something we could all learn. Oh, it's all good. Yeah, that we could use. Melanie?
So the behavioral change or situation that I was in where I received changed it was specifically in clinical, my first actually clinical rotation. So this is my undergrad. I'm only 18 years old. My punctuality is horrible. I'm late all the time for clinical. So that was happening on a consistent basis until you know, my clinical instructor kind of generalized punctuality and kind of said, you guys need to be here on time. But the one thing that I liked about her feedback is that she wasn't stern. She made it comfortable for me to receive the feedback in a positive way and not negative. And I began to change my behavior. So that was awesome.
How did she make it comfortable for you to receive feedback?
Her tone of voice, seeing that she, you know, had a passion for what she did as far as teaching and wanting all of her clinical students to do well in the program and to succeed. So you can just see it in her.
Yeah, and you didn't know her for that long at that time?
No, not at all.
My thing was I was preparing for like job interviews and meeting with some of my mentors and my program director, and my program director actually, when I was just talking through some of my worries and like, you know, and when she was just giving me some advice about her experiences when she went through it, she made an observation and she said, Sylvia, for whatever reason, you sound a little bit uncertain of yourself when you normally don't, and you downplay, you know, your training and your skills, and you know, and she's like, I know you're like, you feel like you're a new grad, you're junior, but she's like, in an interview setting, you need to be confident to project, like, honestly what you really have, and not to actually, you know, try to downplay or be, you know, extra humble for no reason, because she's kind of like in that situation. People want to know that, you know, you can at least be confident. And so I thought, I took that with me to my interviews, and I don't actually know, because I can't observe myself, whether I sounded more or less confident and projected a better representation of myself. But I did think about it and try to sound more certain.
I think that's interesting because I think it's very cultural. I think in certain cultures that is, the humbleness is viewed as, especially in women, as almost a pro. Yeah.
Ladylike.
But yeah, but in other cultures it's not.
So can I just quickly ask
Yes.
too, did she give you a suggestion on how to improve? Did she suggest videotaping yourself, having somebody do a practice interview with you? Was there any suggestion there?
She did suggest practice interviews, but no, she didn't specifically.
I'm thinking that that's very interesting feedback because she was actually addressing your attitude as opposed to the technical skill. And she managed to, to somehow resonate with you. That, what you were adjusting was your passion, your enthusiasm was appropriate, and that you were allowed to then, build on that.
And the interesting thing is it's a fine line between addressing attitude and that can be changed. Things that can be changed versus personal characteristics that cannot be. So she must have seen that you were capable of improving that.
Right. But I think the powerful thing of addressing attitude, and it's by far the trickiest, is if you get it right, as she did, then the technical skills fall into place.
And maybe the characteristic about that was just what she took from her experiences that made it relatable.
Right.
I think that's what she could identify because of.
And have you known her for a long time? Is there
No,
quite a
actually.
relationship?
No, so we have a relationship, but she's a relatively new older, but.
And what was kind of the environment you were in? Was it very one-on-one?
Yeah.
And other people?
No, it
in
was
the
just
room?
one-on-one.
Sally?
Yes. It's an interesting that I'm still struggling with this. With many consultations I did with many classes. Before 14 months, there is one class, this class in New York. So that's class about how to assist you in doing the presentation. They are doing just only, they will ask you before you get in the class to do 5 minutes presentation, and after that they will record you and will give you the points, what's the weakness. The feedback for them, did that and read it from the slide most of the time. But that's very short presentation. I'm still hesitant to look to the audience. Sound loud. My sound is low. I need to make it more louder. So they try to adjust my attitude during the presentation.
Give you very
using
specific.
body language. I'm using body language.
Use what language?
Using body language during the presentation.
Body language.
I'm using 10% of what I supposed to do.
Yeah. And did they give you
They give me a report.
like we asked the other, did they give you specific ways to improve on that?
Yeah, they did like you should put yourself at the mirror with yourself.
A mirror, okay, yeah.
The camera is the best because it can record your voice. The mirror, no, because it will be the echo, so you cannot adjust your voice according to that.
Is that why you bought the camera?
Yeah.
So Sally
Yeah.
implemented that feedback
Yes,
and gave an awesome
exactly.
workshop.
Exactly. Dr. Bada, did you have anything or did you want to pause?
Oh, yes. Sooner or later, everybody will have a visit from the college for their license. And I knew I would get one just before my 70th birthday because I'd never been visited before, but actually it came 5 years early because at the moment they seem to be going through all the academic units. So I was kind of expecting this would happen. And half my colleagues were ahead of me, but it was quite interesting to have that feedback debriefing interview after somebody had spent 90 minutes going through all my charts. It was quite, I mean, really high stakes.
Yeah.
Am I going to lose my license or not?
Yeah.
But I found that they were well trained to do this. And the specific thing that I was told had to do with using a tool within the suite for the electronic medical record. So what my assessor discovered, and something I was totally unaware of, was that the whole suite, the software program, is lacking a patient contract around narcotic usage. And I didn't know we were missing it, and everybody else had already had their assessments, and nobody had mentioned it. So certainly, as soon as I got that feedback you know, once I had shaken the gentleman's hand and he was at the door, I was down the hall saying, "Woo, guys, you know, we're missing this from our suite of all the bells and whistles in the EMR, and this is the thing that the CPSO is chasing this year." So it certainly, I then created one and started scanning them in, but it was certainly very effective feedback.
Yeah, very specific.
And I thought very appropriate. I had no trouble saying, yeah, you're right. I need to fix that.
Is the attitude of these auditors more, supportive, or is it more
Oh, they're
punitive?
enormously supportive. It's
Right.
like, sit down. Are you feeling okay? Please don't faint. Don't need a glass of water. And they send, all the letters ahead of time are tremendously supportive and keep emphasizing this is formative feedback.
And
We
we're
don't want to take your license.
So we're a self-regulated profession, and I think having that external feedback from our colleagues could be so helpful.
And it was true peer, like they had to go and find some old guy from Queens who was an academic to come and look at my charts.
Thank you, Dr. Rai. I think it demonstrates that receiving feedback and learning is really like, we have lots to look forward to. Eugene?
It's funny how much I can relate to some of the other feedbacks, actually. But mine was a very simple example of learning to play golf. It was from a cousin, actually, who had 10 years of experience, and I thought he was a great golfer. So the feedback in a sport or a skill with golf, it's in the moment, it's right away. You change your behavior immediately, and you try to practice that skill consistently. The problem was when I went, after developing a swing of sorts, going to like an instructor later, you find out all the bad habits that you developed, and it's very hard to change, actually. So I think that's sort of one of the interesting points about that feedback, where if you develop a behavior pattern and you continue it for a while, sometimes it's difficult to change your behavior. Not that it's not doable.
You actually highlight something that we'll talk about in just a few slides about informal feedback and giving feedback on the fly and giving it early so that you're able to change behavior before it really sets in. So, thanks. Matthew?
I'll use so when I started doing my continuity clinic as a PGY3, I was still in internal medicine, but knew I would get into nephrology, so I started a nephrology clinic, and the program director of nephrology that I would work with later on was supervising me at first for a few clinics. And we do not dictate letters quite early in our training. We dictate summaries, but letters are different. And part of it is also teaching the person that referred the patient to you so that they can learn from your consultation, not only give the info about the patient. And honestly, at first, my letters were terrible. Totally disorganized, you couldn't really get something from it. But all the content was there. So my program director took me when I had a minute he saw me passing back and forth. And he told me that for him, it was a challenge too at first, especially that French was not his first language. And he told me how another doctor showed him how to do the letters. Then he showed me one of his letters compared to mine so that I could see what I could improve. And then told me like all your content is there and helped me organize it. He asked me to do it again and that we would review it. And we did for the next letter I've done too. And then I think really improved. And on top of it, because he said that he had his own limitations with his letters, he put me with the same doctor that learned him how to do his letters for the following clinics I had so that I could get his tricks from it. And I think I do good letters now. That primary care physicians do get something good out of my letters and are interested in reading it, or at least reading the impressions and recommendations in the end and can learn from it. And I tend to be more specific even myself about what I tell them, like, do this, if that, in those situations, do that, and even come up with if this or this happens, do this and that, and only if. So it's I guess it's much more clear than it was before. It really helped me, and I totally changed my behavior onto this, and it was early, so I used it for several years, and I guess I'll use it lifelong.
I think that supervisor did something, yeah, facilitate change, yeah. I think he did something that was tremendously important, which is to provide follow-up. I think sometimes as we rotate through, you know, because maybe as you go into your staff it's a little bit different, but when you're a resident learner, you rotate through rotations that are 2 weeks to 4 weeks long, right? And sometimes it's very hard to follow up on the feedback you give them, especially if you give it to them at the end. So I think he did something that really promoted change because he followed up on it, right? And it's such an important skill and something that's not always taught on a rotation.
No, and he did it very well for various things, and then it was important because I was alone, so I couldn't even ask another resident to help me out because I was the only one.
Yeah.
The good thing is that I was doing most of my 2 years, like say 22 out of 24 months in the same center, so he could follow me up.
And like the other good thing that he did was he also like demonstrated like how you could do it well, and like he would just say, sort of give you like nebulous suggestions like a few times.
Very practical.
Yeah, and one of the things that helped me the most was that he told me, like, I had the same problem as you had. Here is how I got to correct it.
Yeah, it's very authentic.
Exactly. That was very helpful and easy because it's not just like, oh, I'm really bad. I guess that like most people get through this.
Yeah.
So it's, I don't know, this helped.
And the feedback was so valuable because it was from a role model who just kind of went through the same process and gave it their experience to make it tangible. That's it.
Good morning. I think I wrote a lot of ideas there, but I would change my mind. So, one of the examples, which is the first month in my clinical fellowship, which is in medicine, I was doing the ultrasound rotation. And one of the sonographer, which is, I mean, the best sonographer there, although she's just graduated 2 years, but she's the best. However, I was with her doing ultrasound. Unfortunately, my mobile was, the alarm sign was on, which is, I mean, start to ring. I was doing scan of the patient.
Pager, you mean?
No, I mean my phone.
Oh, your phone alarm, oh, okay.
And it was, for me, yeah, I said, I'm sorry, that, and for the patient, I'm for the sonographer, and at the end of the day, she told me that, I mean, you have to switch off the file. I said, yeah, I did mistakes, which is okay. It was specific. And at the end of the month, when I received my evaluation, I noticed that she wrote it down that he is putting his mobile on during this, which is, it was strange for me because it was, I mean, it wasn't intentional. It was, I mean, accidentally. So I say, I get angry from my inside, but however, I accept that, which is just to complete the story. At the end of my fellowship, I did another rotation in the ultrasound, and it was with her. And unfortunately, her mobile was on. And she received a call. And so I didn't say direct comments to her, but she realized that she did mistakes. But from my inside, I said, do I need to write it in the evaluations? Or not? So, but I wrote it down at the end.
So it's a great segue to something to talk about later when you're fostering a culture of feedback, providing that two-way ability to give feedback.
The benefit of revenge feedback.
And finally, Annika.
The one feedback which I thought was great, it was more of a feedback experience, I guess, in my fellowship last year in Calgary when I was doing my research and my papers, etc. And doctor who I'm working with, he's like a world-renowned surgeon. And it's just the way again, the feedback used to be, because it was something which we were working on together. There were several feedback, but they were very, very quick in succession. He even though he was very busy, and he was very available for feedback. So there was a situation where I was actually looking for feedback, and he was very available and would give it readily. But the whole atmosphere which was created was so great that, you know, I never felt that I was some junior person. You know, he just that respect and a safe environment for feedback. And
how did he do that?
Pardon?
How did he create that?
Yeah, it's just that the way he spoke with you, discussed things, it was as if I knew just as much as he did. You know, in reality, I did not know that. And also, you know, just the fact, I think one thing which maybe you all will mention later, which I really struggle with, is to make my learners know and really realize that this whole process is for I mean, we are working towards one single goal. It's the same thing. And I struggle with that with my kids because when I give them feedback, they think I'm thinking of that.
We've all been through that.
So it's just that thing, just that one thing which I'm trying to cultivate, because he created it, because it was as if we are all working towards the same goal, and it's just something to help us along that way. You know, I feel that just the way he treated you and the way he wrote down his suggestions were just the like suggestions that I had to change or not.
That was some really great discussion, and I think in terms of behavioral change, you guys gave us quite the spectrum from hobbies to your personal life to our professional life. So really, we could elicit and receive feedback in all aspects. And the characteristics that we talked about, I mean, I'll focus on in a little bit, but it seems like most of them we will elaborate further on, but you definitely touched on many of the characteristics that we have also seen in the literature. So just moving on. This is just, the next segment is going to be a quick summary of strategies on giving effective feedback. And then later on, Kristen and Rahul will go into more specific strategies. So characteristics of good feedback, we talked about most of them. We just compiled 6 major ones from the literature, and we touched on most of them. Feedback that's well-timed. It doesn't have to be right after an event, but it should be relatively soon after that the events are fresh in both the learner and the teacher's mind. Has to be specific, focused, and not to overwhelm the learner. 1 or 2 points that they're able to retain. Descriptive. Literature has shown that descriptive feedback is much more successful at improving student behavior than evaluative feedback. So just a number, as opposed to descriptive, where you are able to give them didactic feedback. Constructive, I think that's pretty self-explanatory. Ideally, feedback should be solicited to the point where you have built a relationship and trust and almost a mentorship with the learner, that they feel comfortable asking you for ongoing feedback. And finally, this is hard, feedback that's authentic. That you don't sugarcoat anything, and I think as we have talked about before, it's hard to receive feedback, especially the bad feedback. And so Kristen will talk about sort of ways to increase receptivity to feedback in the next segment. For those of you who are visual learners, we just wanted to give you a bit of a breakdown of how we see feedback as. It could be both informal or formal. So informal feedback is sort of teaching on the fly, not structured at all. The learner is not aware that after this period of time, he or she will be getting feedback, sort of like Eugene's example where he was getting feedback when he was playing golf. The idea of that is to really see the learner on a day-to-day basis and give him or her feedback early on so that he or she is able to change their behavior early on. Whereas formal feedback, I think we're a little bit more familiar with, is structured time to receive feedback. And formal on its own can be broken down into formative and summative. And of course, there's overlap in this area. So in terms of formative feedback, this is also ongoing, but the student is actually given time for this ongoing feedback. So an example that's often used in family medicine is that of field notes. It might be called something different in various areas, but the teacher will observe the learner via video or standing in the room, and he or she will fill out cards. What was done well? What could be improved? Are you ready for practice. Anyway, it varies based on your institution. And then time is set after clinic to discuss this. And ideally, this is to help students identify their strengths and weaknesses early on so that they're able to improve. And the formal summative feedback, we're also probably quite familiar with. This is the midterm and final feedback, usually in most rotations, where it's after a chunk of time, the evaluator and the student have spent some time together and they're able to consolidate the feedback together in a more formal setting. This is usually compared to a benchmark. This could be evaluative with that Likert of 1 to 5 that I'm sure we're all familiar with, or it could be descriptive or a combination of both. And ideally, the learner should be getting formative feedback or informal feedback throughout their rotation so that the summative feedback is not a surprise to anybody, ideally. We just wanted to touch upon three strategies that we found in the literature that are quite classic, and then we will further expand on one later on after the break. So the Pendleton's rules, the other group also talked about, it's classic feedback strategy, published in 1989 by Pendleton et al. And it states that you should give feedback in these 6 steps. So 1, check when the learner is ready. 2, ask the learner to say what was done well, and then the teacher will state what was done well. Then ask the learner to say what was not done well, and the teacher could say how this was improved upon. And finally, action plan for improvement. So this is sort of the classic literature. It's been critiqued in that it's very teacher-driven, and it is a little too structured. There's been another principle called the ALOBA principle, which Dr. Batty also talked about in her teaching learning part A. Stands for Agenda-Led Outcome-Based Analysis Principle. It's published in 1996 by Silverman et al. And this, I believe it was first developed to teach procedural skills, but you could also use it, you could adapt it for any other setting. And it breaks it down into 3 steps. So 1 is establish a rapport with your learner, identifying the learner's agenda and their desired outcomes. So setting a time to do this before the rotation. Doing the experiential work, whatever it is, whether it's a procedure, whether it's just a patient encounter, and then closing the session and summarizing the learning points based on the agenda and the objectives and the outcomes. And then ideally you should loop around 2 and 3 until their outcomes are met. And finally, the last principle we wanted to touch upon is the KISS method, which we thought was cute. It's taken from the James Cook University. It's kind of a modified sandwich model, I think you think of. So it's keep what you're doing right, stop doing what you're doing incorrectly, and then start doing what you need to do to improve. So an action plan. And I think, was it Christine and Melanie's group, or I can't remember who's group, I think it was your group. You guys sort of used that model when you were doing feedback. So that's it for this section.
So I think that we're at the time of the break, and we'd like to give you that full break. So we're just going to modify our agenda, so you can have your break from 9:30 to 10, and when we come back, we'll start with the mind didactic session and then the activity.
And just to reiterate the kiss method, you guys want to pass around some chocolate kisses. There are nuts in here, though, so if you're allergic.
Sadly, I was thinking you can kiss the person next to you.
There's a lot of things I'm thinking. Oh yeah, I think
something
But you would, which is the main thing. Like I didn't say
in a certain way, there, with the
We can give them names.
Yeah, I'd love to help us all out. That's where?
That's amazing. That's yeah, they're extra
and you can verbally say it. I've noticed that happens a lot of times. So you get it's not that feedback, but positive. Yeah, it's criticism.
Yeah, if you select a based on your
verbally it's one thing, putting it in writing. I mean, I think taking the positive out of the feedback, I mean, she had a point to this, but I think the bottom line is for human.
That's great. Just tell you, like, I know. That's kind of like what's so
But I mean, you cannot really identify who will have more medication and things like that.
like just proportionate. I don't know, it's also and I'm culture is sort of about
Yeah, maybe that's why I
I would Is it a fun read? Like, is it, or is it history? Right.
So you wouldn't break it down, you would just like people that would particularly.
Oh, there's a little, like, okay. So it's like a movie. Okay. Which section was it? Oh, okay.
Yeah, because you don't know, that's for sure. Because it's too. You won't be able to compare it to not if it's your school, their business.
Problems are, and they are it already.
There's a guy in Quebec that
No, I think we just have to figure out how to do that.
he's the
Yeah.
worst psychopath.
Oh, okay.
We have one.
No, I haven't.
Yeah.
He scored like
Like we have one.
9%
The actual
psychopathology score.
this
And his risk of recidive
So it's really gonna
of
be like a
sexual
number.
assault in 2 years is 100% if he gets out. And his risk of like violent or like severe violent act or murder at 10 years is like 100%.
Oh, well, they only.
Yeah, they put it in the- yeah.
Oh, I see. Oh, I see. Okay.
But we can work on it.
In Quebec, what they're using right now is kind of a provincial thing where they
Somebody's watching me last
kind
night
of
through the window of my house, cause like I practice like I'm talking to people, so I'm like, I look like I'm talking to myself.
You guys have never been set up.
One easy, yeah, we need space, like they wanted to go over there, but then it, so we're.
There's like all three of you.
Yeah, it's too
No,
cramped.
it's a good setup.
So I'm gonna go here and.
I love these folders.
Yeah, the folders are awesome.
Yeah. Well, we were like, okay, because we keep being told it's high, like the last, there's so much higher expectations for the last people. So we're like, okay, at the very least, if we implement the suggestion she's already made, that's got to count for something. So like names on the names on the thing, throw in the
You guys are
folder.
very polished.
Yes,
It feels like you guys have been doing this for a while. Like
Oh,
it
that's
feels
really
like,
nice.
like Shirley's presentation, you know how, you know,
No,
like,
sure, yeah.
given the talk, like, you know, she's done that workshop like multiple times.
More than
Like,
once.
That's kind of like.
Well, this will probably be about the 10th time I've given this talk, including the 9 last night. So, like, do.
The cards?
Yeah, that's smart. Some more losers are selling them, or you're bringing them in black and red now?
Kristen, what's the origin of your last name?
German. Yeah.
Your patients just call you like
Dr. K. Yeah. There was the only one patient I ever had who could say and spell my name was a 6-year-old.
You don't even have two parents.
No, but I have, you know, I was. Okay. Yeah, I just read this. And they let you do that.
Were both your parents German?
No, my mom's from Italy.
Oh, really?
Yeah. So she's from Southern Italy. Like she came over when she was 4 with her family. So I'm full, one half is full Italian and the other half is hodgepodge. So there was one, like my dad's dad was German.
Oh, okay. I see. So just the names kind of appear that.
Yeah.
The Canadian several generations. Your parents.
Yeah, he would be, I believe, only second, I think, because his grandparents were not born in Canada. So his dad would be first generation. His grandparents were not born.
Technically, I think he would be third generation.
You would still be third, even if they were the ones that moved here?
His parents had moved here, then he'd be second generation.
Okay, so his grandparents moved here, so then he'd be third, yeah. But my mom's first, then.
Yeah, exactly.
Oh, yeah. The cream of course, that's where. Also, there are. Oh, actually, I don't need to mention. There was. That was like. Those walls. Is that what it costs too? Is that what also? But then I have to go all the strengths that actually sound just. Oh, once you on to the side.
So sometimes people say, oh, what family dollar, just what a bakery.
So what would you do to select people to go into the business? Would you like MRI to screen out those dangerous people? And look at the marks. It's just like the close-up inspection, you would use the marks. But there's a lot of reasons. Because I think it's actually want to get in there.
I think that's it.
Yeah, but then
Maybe you could do.
they have like. It's like gets out all
Because when I practiced it last night, like if I go right, I'm supposed to the slide and I don't divert, it's fine. And when you look at what I'm doing at the end, like my last presentation only has 10 minutes.
Yeah.
But like, that includes the stand up and be counted, which you can make less than 10. The wrap up is 5, and then the iPad process is 5, which will like take 2 minutes. So I think it won't follow our scheme, but there's enough time in there.
Yeah, that's true.
So I'm not too worried about it.
Okay.
That's what I thought. They're gonna get sued sometime. That's what I was
They
wondering.
gave up what I think is
I think it's because Annika told me. So she's not actually like that. I think there's 10 people today. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. No, you're
And I
right. And
see
12.
those. When I was in college, actually.
1, 2,
when I was in
Matthew's here.
college.
3, 4, 5, 6, 7, 8, 9, 10,
Those
11.
people that wanted to get in business.
Yeah.
I'm always absolutely like opposite of what they like.
Yeah.
They're supposed to.
Overwhelming.
I keep getting 11.
Managed to finish it.
Oh, I put something together at the end.
Yeah.
But I don't think Dr. Riley will break down.
Don't let it. Yeah.
That's that very similar one to like.
So as long as I have 5 minutes.
But, yeah.
No, oh my god. So second we're
That's really what I want to do.
and just like I used to have blogspot back then. So my sister, her
For what it is, but I actually sort all
and she's like, what? This one has
Very user-friendly.
yeah, she's like, it's helpful if you need for it. All you need to do is just kind of wait. The only thing that was a little bit very hard for me was that I was unable to.
Maybe it's not working, but I think.
So,
Alright.
but when I say that, it's not as
The purpose of logging in because it's not
no,
That's on the left.
You actually produce it?
No, it's like, no, it's just, so I think in the interest of time, I'm gonna get started.
Okay, great. So I'm going to be talking to you guys about student-centered feedback. So putting the student as the central focal point of our giving of feedback. So kind of revisiting, well, the current state in the literature is saying that a lot of techniques for improving the feedback process is focused mainly on the tutor and feedback delivery. So students' perspectives, or at least they felt that their perspectives have been largely ignored, and students still feel that feedback is a process done to them rather than with them and including them. So kind of now we're going to revisit the definition of feedback that we've compiled from the literature. And when you ask students what feedback means to them, they still acknowledge that it's information on performance, that they use to aid improvement, but they also view feedback as a form of encouragement. So students have identified some characteristics of feedback that make the experience positive for them. And there's a lot of overlap between what the students perceive as leading to a positive experience and the characteristics of quality feedback that we've already listed. So feedback that's constructive and specific, that outlines some tangible suggestions for improvement the students can work on. The third and the fourth point I kind of combined. So feedback that's given on the basis of direct observation and in the setting of a respectful dynamic between the student and the feedback giver. And why this is important is because students deem feedback that's based on direct observation as more valid as opposed to seemingly pulled out of thin air. It also serves to create the dynamic of respect between the learner and the teacher. And having that dynamic increases the credibility of the feedback that's being given to them. So if they view the source as credible, they're more likely to be receptive to it. Also, feedback that's balanced. So feedback that focuses on strengths as well as areas for improvement. And why this is important is because it's just as important for somebody to tell us what we're doing well as it is for them to tell us what we're doing that could be changed or corrected. Otherwise, there are certain things that we may possess, skills that we use, that we've adopted, that are actually serving us quite well, but if nobody reinforces that, we may question it or drop it in our future encounters with patients and our future practice. Now on the flip side, according to students, there are factors that can make the experience quite negative. And one that I've highlighted because we're going to visit this more later is feedback that has a negative emotional impact. Also, feedback that's not standardized. So I don't know about you, but there have been times in my training where I've received contradictory feedback from different sources. And then I'm left feeling like I'm sort of in it alone, and I don't really know what I should be taking with a grain of salt and what is a universal truth that I should apply in the future. So some of the literature says to avoid personal opinion. And I would say to kind of go one step further and make it clear when you're telling a student that's feedback based on a black and white universal truth in medicine, and when feedback is based on your opinion. So I had a preceptor that did this exceptionally well. She acknowledged when she was giving me a suggestion for change based on something that is debated, heavily debated in the literature. There's more than one way of doing it well. And she would always preface it by saying there's more than one way to skin a cat. And by doing it that way, she didn't knock down what I was doing, and my ears were open to the other ways of doing it, as opposed to shutting down and feeling defensive about my way that I had read in the CFP last night was fine. So other things that contribute to a negative experience is feedback that's evaluative rather than descriptive. And the literature consistently says that verbal comments are received far more positively by students than evaluative alphanumeric grades. The purpose and content of feedback is unclear, either to the preceptor or the student. So my example of this is when you have your standardized feedback form, but really given remotely from when the rotation was, so several months down the line. And if it was negative, there's no opportunity for change. So the purpose and content needs to be clear in that the giver and receiver of feedback needs to know how that feedback fits in the larger scheme of things. It's not enough to just give feedback. There has to be follow-through, opportunities for improvement, and a reevaluation of what was initially given feedback around. And then also feedback that relates to a student's personal characteristics, because you're kind of antagonizing that improvement process. You tend to be insulting the person on things that are either inherent personality characteristics or physical attributes
that they can't change anyway. So they leave feeling kind of insulted and nothing's going to get any better. And it also contributes to that negative emotional impact. Things that we need to consider, one is the feedback gap. So there is an incongruence between the amount and quality of feedback we think we're giving and the amount and quality the students are perceiving to be receiving. Considering your students on a novice and expert continuum as opposed to the chronological point in their training. So for instance, you may have a senior student who's quite expert at history taking, but novice in terms of inserting central lines. And if you look at the literature that talks about maturational issues and suggests that junior learners want more encouraging feedback and senior learners want more potentially harsh, to the point, succinct points of improvement, you may be missing the mark for a student who is senior in chronology, but novice in the task you're giving feedback for. And then the emotion, memory, and feedback legacy, and this ties into a lot of the stuff I'll speak on later. So the bottom line is feedback that elicits a negative emotional response, or feedback ill-timed in a student who had an untoward event and is in a negative state of mind to begin with. For instance, post-call, having lost a patient, just exhausted, or something going on in their personal life. That negative reaction is going to persist far into the future, so much so that they will probably have not even recalled what the feedback was given in the first place. So they may continue to perpetuate things that they should be changing or lose positive attributes because they were in such a negative emotional state, and that will stick with them. Other considerations are the three factors. Sorry, this was to read 1, 2, 3. I think when we compiled changed. 3 factors that influence the effectiveness of feedback. 1, the credibility of the person giving feedback we've addressed. I really want to highlight the message, and that's what my next 2 slides are my next slide is focusing on. And then in terms of the recipient's readiness to respond, so we've kind of addressed some attributes of feedback in the context that increase receptivity, and this will be expanded on later as well. So in terms of improving content of feedback, McKinley et al. Stated that this is a largely neglected area of feedback. And they suggest that whenever you go into a feedback encounter, you be able to answer to yourself 5 questions. What was performed well? What could be performed differently? What was missed? What is the priority for improvement, and what the learner must do to improve? And I've bolded these because this speaks to taking a step further and facilitating an action plan, opportunities to implement it and follow up. So we tend to be good at the errors of commission, 1 and 2, what was performed well, what could be done differently. Step 3 is where we struggle a little bit, because chances are we're providing feedback on a skill or behavior that we're consciously competent and it's automatic to us. And so I just want to tie this into to teach us to learn twice, because in order to identify what was missed, we almost have to deconstruct our knowledge to the unconsciously incompetent level to bring the learner up to the level that we're at. So it takes us through those stages again and enriches our understanding of what we're giving feedback on. In terms of the priority for improvement, this is my segue into talking about self-directed is not do-it-yourself. We are aptly suited to tell and help a learner become aware. So maybe not tell, but help them become aware of what they don't know they don't know. So they may be given feedback on something very specific, but not have the first clue based on their stage of training where the first step should be, what the next rotation is going to provide in terms of opportunity for practice and change. And that's where we come in, because we know at their level what the priority for improvement should be and what opportunities are more likely to come their way at this stage. And then what the learner must do to make improvement, this can be negotiated once you've identified your priority. So very briefly, this is a resource that we just wanted to share with you. I highly recommend it. It's very succinct. It's 4 pages, Rudlin et al. And this figure really highlights the crux of what we're saying about student-centered feedback. So you have the student as the central focus. The supervisor and the context that they provide envelops and supports this process. So it's just as important for the supervisor to be learner-centered, expert, and good interpersonal skills without losing sight of our student as our focal point. And the student needs to be responsive, receptive, and reflective. And in my second segment, we'll talk about how breaking down barriers, creating a positive experience, and those 2 things can kind of contribute to increasing receptivity and ultimately creating feedback seekers. In terms of the context, we need to use our skills to provide feedback that is well-timed, allot the appropriate amount of time for feedback, know when it's appropriate to generalized feedback to a group versus directed and private to an individual. And then this segment of the diagram uses the acronym PROMPTED, which is simply a memory tool for you to organize characteristics of quality feedback. So the next slide I won't read through, but kind of outline some of the qualities of effective feedback using this acronym. And ultimately, these all come together to help guide the student to their learning outcomes. For some reason, this is a bad analogy, but for some reason I think of that thing that they go down in Hunger Games. I don't know why, like the students, but like the more positive outcome. Like it's an elevator or something. So this is just the acronym PROMPTED. So that's my didactic segment. So our next section is going to be a chance for you to test your knowledge on what was already said to you. So
Sally, turn it over. Don't look.
Yeah, don't look.
Away.
Okay, so we're going to play Family Feud because we thought it was super fun. So everybody who has black cards line up on one side and red cards on the other side. Dun, 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 dun. The theme song.
Oh, I'm not in Sally's team. He's usually the best.
What is it? Black?
Yes.
Black card,
Red card.
Black here, red here. So volunteer a team leader to come to the table. One of you has
Oh
to
no,
be the
Annika, you're on the red team. I like being on your team. She plays to win.
Okay.
Wrong.
So we're going to explain this. We'll do the question after. We'll explain it. So we're going to have one team leader. You're going to come here. We're going to ask the question, and the first person to tap gets a chance to answer. Because we did not poll 100 people to rank order these answers, if you select an answer that's correct in any order, your team gets a chance to play or pass. In the interest of time, 2 strikes and the other team gets to steal. Okay? So, first question. Do you have your fingers at the helm?
Somebody needs to go up. Who wants to be leader? No, I'm very
It's designed for you.
Oh, you don't
What do I do?
Yeah.
Very good.
Just hit the table?
Just hit the table.
All right.
Yeah.
Oh,
Okay.
no, the camera.
First question. What are 5 characteristics of positive feedback experience?
No, you
We
just
need to name
one.
one, or?
Yeah, name one. Ding, 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 it's specific.
There's 5 on the list.
You're gonna play. You're gonna play. Yay! Team, that's you. So, one of 5 characteristics of a positive feedback experience. Based on my presentation. No, it's just you.
Oh, based on your presentation.
Yeah. Not based on that.
Can we confer? Yeah, can we?
No,
No,
you have to. You have to
5
do-
seconds.
You guys could confer to Steve.
Oh.
Yeah.
But you guys.
One characteristic of a positive feedback experience for students.
Give us the slide.
Okay, she says supportive. We do have respectful
Respectful.
dynamic
Yeah.
between the learner and the Okay.
Attainable?
My goodness, stop that.
Sorry?
Attainable, something which can be.
So you mean
achieved.
tangible,
Tangible.
constructive? Ding, 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 ding.
Wait a second.
You're generous.
Yeah, I'm the attitude
There's a
more
bias.
fuzzy person.
I'm gonna say descriptive.
Although you are correct, it's not one of our answers. Okay. It was based on my presentation.
Slay.
Yeah.
I think we get
Sorry. So, your chance to steal.
Yeah,
There's
but then
2.
what do you do with plagiarism?
Okay. One positive feedback experience characteristic from my presentation. You get a chance to steal.
All right, we're gonna go with timely.
Okay, that's right, but it's not one of the answers. We'll put direct observation and balance.
I don't think that's
Okay, so you all get a kiss. So pass those down. So one more question for you. So next person in line. Name one of the 5 characteristics of a negative feedback experience. So we need the team leaders here.
Who's gonna face it?
So you have to do a face-off. So you can think of it. One of 5 characteristics of a negative feedback experience.
Somebody needs to pass.
Okay, indirect.
The
opposite.
The opposite.
Yeah.
That's a good call.
Yeah, that's not one of our answers. Would you like to steal? It is, indirect is an answer, but not one of the answers.
Indirect feedback.
Okay, next time we're going to organize it.
We'll play to steal.
You'll play it?
Yeah.
Okay.
Yeah.
Don't you have stuff? So like evoking a negative emotional experience.
Ding, 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 ding. Yes.
Good job.
Okay.
Going.
So 5 seconds.
Are we going like individually? We're not.
No, just as a team.
Yeah.
Oh, okay.
So who's next? Is it?
Oh, I thought it was Oh, who's going next?
Why don't you go?
They're plotting over here.
I don't know.
Just guess something. Okay, so well, I guess what, for the interest of time, we'll give them a chance to steal.
Yeah.
Okay.
It shouldn't be directed at something personal. which
Ding,
is
ding, ding,
feedback.
ding, yay! So for knowing, so we'll go through the other answers. Not standardized.
You wanted to go with
Evaluative,
That was the
so
winning team.
alphanumeric grades rather than descriptive. Unclear content. So this team gets closer to diabetes.
Still have to hear. You guys can still have kisses.
You guys thought the fun just began, eh? So now we're going to change gears a wee bit. So the next part we're going to focus on is enhancing feedback skills. So basic overview, we're going to review some key concepts and principles related to developing and refining feedback skills we learned in our first excellent workshop. We're going to go over specific skills, primarily the 1-minute preceptor model that we all love. And we're going to illustrate an example of the 1-minute preceptor using role play. And then you guys can all demonstrate your talents with some case examples. So some of the underlying principles, a few of these are kind of just honing down on some of the themes we talked about. So the purpose of feedback should be to improve achievement and performance and not to criticize. So again, the focus is improvement and not evaluative, judging, or criticizing. You know, both receiving and providing feedback can be challenging, but these are skills that can be learned to develop. And what we argue is that practice alone doesn't make perfect, but it's practice with effective feedback that can lead to perfection. We look at bridging that gap between giving and receiving feedback, some of the general themes. So it's important to observe the learner, then we have concrete examples we can provide in our feedback. The feedback discussion with the learner should be based on observations, as well as allowing the learner to give their perception and views on how things went. And then again, using the feedback to create that culture of improvement. So the feedback provider, some practical tips we came across, and again, this is just a lengthy list, but something you guys can hold on to. So again, it should be viewed as a positive activity and just as a mere conversation. That's when it works best. Routinely, we should be making time to provide feedback. I know we're in busy clinics, and it may be difficult to balance teaching and feedback, but making routine time, whether it's at the end of the clinic, has been shown to be very helpful. Some of the skills, I mean, our learners are very smart, but literature has shown that they don't always appreciate when we're giving feedback to them. So sometimes making it very explicit that, now we're going to sit down and we can give you some feedback on what you did well. It should be timely, so as close to the observation as possible. So again, if now it's June, talking about something back in January might not be the most tangible and relevant. I can't even remember what I ate for lunch yesterday. So keeping it as timely as possible usually works best. Engaging the learners in that reflective process on their self-assessment and goals to improve. Being specific, so saying that, maybe instead of saying, you didn't have good rapport with the patient, saying that, having the computer in front of you can be distracting. Maybe by maintaining more eye contact, you could have built that rapport a bit better and the patient could have felt heard. And then being prepared to implement that feedback and providing kind of our novel learners, especially some tools maybe on how to implement that feedback. And the last thing for us, participating in activities to enhance our feedback skills, like 2 wonderful workshops that we've had. So the 1-minute preceptor, I think, is an amazing model. It's just one tool. Yes,
I was just thinking about the last slide. I mean, I 100% agree with every point. I'm just thinking practically about how feedback often works, and I think that the reflective part often comes from the person giving the feedback initially. Like my first emotive response is, how did that actually go? You kind of get this feeling it was good or not good. Sure. and then you kind of try to figure out what exactly didn't go well or went well about the session. So I think that in giving this type of feedback, we also need to make sure we take that moment or time to actually figure out
what they're saying.
Have you read ahead? We pay them to.
I will wait, and I'll come back to practical ways to stimulate reflection. But maybe I won't need to.
No, time will tell. Excellent. So the 1-minute preceptor involves 5 micro skills for that one-on-one teaching. And what we seem to love is that you can really customize your teaching. As opposed to being in a large group, it's kind of hard to find every learner's individual needs. But when you're one-on-one with them, you can make a big difference. I think the best part is that it's flexible, so you don't have to use all 5 micro skills. You can tailor your feedback and your teaching and feedback accordingly. It can be used for most clinical teaching encounters, and we argue that it's very effective and also time efficient. It was first coined in 1992 in a great article titled "The 5-Step Micro Skills Model of Clinical Teaching." And since then, there's been a flood of great articles. Some of them are in your reference list as well, in nursing literature, medicine literature. I know in Toronto they use it in psychiatry and family medicine, as well as internal medicine.
But notice it came out of ambulatory teaching in family practice, where the time crunch has always been a challenge.
Great. So again, we're all in busy practice. We're having more complex patients. We have more learners now that are getting entrance into medical school, and really finding that time for teaching and feedback can be challenging. And I think, as being in this class, we all love teaching and providing feedback, and we should really find tools to make that, to allow to survive in clinical practice and allow education to thrive. So we argue that the 1-minute preceptor model, really provides a structure to maximize the amount of time and effectiveness in teaching and feedback. Some studies have been done that the average teaching encounter, or teaching and a discussion of a case takes about 10 minutes. Often, it's quoted that there's about 6 minutes for the case presentation by the learner, 3 minutes for questioning and probing and just trying to better understand the scenario, and then about 1 minute for discussion. And I think using the 1-minute preceptor model, we're able to kind of combine those probing, questioning, and discussion to make it a lot more time efficient. So the gentleman's holding a golden apple, because I think the 1-minute preceptor is that golden opportunity when you're one-on-one with your student to really make that difference and allow them to thrive. The first 2 micro skills really focus on getting to learn who your learner is, what their basis is, what their knowledge is, and reasoning. So the first step is getting a commitment. The second step is probing for supporting evidence, and we'll go into more detail in examples. The last 3 really remind us to target our teaching and our feedback to the specific learner and their needs. So it's about teaching general rules, if applicable, reinforcing what was done correctly, and then correcting mistakes, or just giving them strategies on how to improve. So the first micro skill, getting a commitment. Really the goal is to encourage the learner to push beyond their comfort level and to commit to a diagnosis or to a management plan. And really the rationale is that it actively engages the learner and helps us as teachers focus our teaching efforts. So some examples would be, what do you think is going on with this patient? Or what diagnoses do you consider in this setting? Or how do you think we should treat this patient? So really getting a commitment from the learner is what's advocated as the first step. The second step is probing for supporting evidence. This shouldn't be the pimping that we all worry about when we're in internal medicine rotations, but it should be supportive and allow our learners to thrive. So really it's uncovering the basis for our learners' decisions. You know, is it a mere guess, or is it truly based on factual knowledge? The rationale, again, is it allows us as teachers to really see that mind map that's going on in the learner's brain and level of competence. So some examples could be, you know, what major findings on your history made you lead, you know, or led you to a particular conclusion? You know, were there other options you considered and eliminated? Why would you choose that particular treatment? So it goes back to our GEM team presentation, really that deep learning and probing questioning and why, asking the question why. That again is microscale number 2. So we have a commitment, we're probing for evidence, and the third one, teaching general rules. So really the goal here is to share guiding principles which are relevant and applicable not only to this case, but to future experiences, which I think is pretty neat. Learners often remember these take-home points. Just in the presentation, we always give summary slides and take-home points. This is really where that take-home point comes. And it's interesting because different modifications of the 1-minute preceptor have the key general rules at the middle, and some actually have amended it to put it at the very end. I preferably like this place when I've seen some cases and when I interact with students. So some examples would be deciding whether a patient has a deep vein thrombosis can be challenging. But fortunately, there's criteria known as Wells criteria that can help us make a diagnosis. So giving them that big picture. Or patients with pyelonephritis, our favorite organ of the body, you know, in addition to the brain, can present with fever, back pain, and dysuria. So the reason we put the picture on the top right is, you know, our learners come with beautiful trees, just to remember that concept of, you know, not missing the forest for the trees. You know, we have these beautiful trees and facts, and especially our medical students bring, but you know, help it, as a teacher, we should let them step back and look at the big picture, that we can guide them in the right direction. And that's where kind of teaching a general rule comes into play. So we have a commitment, we probed why, you know, we taught general rules, and the fourth microscale would be reinforcing what was done correctly, to counting the positives. So providing feedback to learners that reinforces what was done well. And again, we can use knowledge, we can use skills, we can use attitudes. And this really builds confidence and, you know, promotes learners to continue doing what they're doing well, kind of like this model. You know, we're working 30-hour shifts, residents are stressed at times, and you know, getting positive feedback really encourages you and I think has a positive spin. So for example, you know, your case presentation was really organized, you know, you had the chief complaint in the patient's own words, and you provided a detailed history of presenting illness. You included appropriate pertinent positives and negatives in your history and concluded with a focused exam. So being very specific and concrete can be very helpful in your positives. Or I'm happy you considered the patient's financial status when prescribing a certain medication, and I'm sure this will help with their adherence. And last but not least, we have our fifth one, which is correcting mistakes. So the goal here again is to provide feedback to the learner that allows them to improve their performance in the future. And again, learners may not always recognize mistakes unless we as teachers point it out to them. Some examples would be, you know, you stated the child's fever and irritability is due to a viral upper respiratory tract infection, but since they were tugging at their ear, it might be important to also examine their ear to rule out otitis media. Or another example would be, you know, considering the patient's quite dyspneic, in addition to performing a detailed exam, it might be good to get an oxygen saturation and peak flow. So the picture on the right, what I put there was kind of to illustrate that there's many ways of going from point A to point B, or from Toronto to Chicago. You know, you can take your train, you can take a plane, you can take a bus. And so it's not always that our learners are made an error. But I think as teachers, we should share our experiences. And maybe, you know, it might be a bit faster to get there by plane than taking a camel, for example, to get to Chicago. So again, I think correcting mistakes, I like to broaden out into saying, teaching general principles on how to improve. So one thing about the 1-minute preceptor is that it doesn't really build into eliciting feedback from the learner first. And I think that's probably one of the weaknesses that I see in this model. But again, you can tailor it to that teaching interaction, and you can always start by asking, what are your thoughts on how you can improve and affect that? All right, so case example, all put together, what does it look like? So we'll present one case example, and hopefully to model the 5 different steps, and then it'll be your turn. All right. So I'm the teacher, and Nancy's the learner. So Nancy, it looks like you have a case.
How are you today?
Good, how are you?
Well, I saw this 45-year-old female today with chest pain. She's super anxious. Just want to start off by saying. So in terms of chest pain, she's saying that it's burning. It's sort of right here in the center of her chest. It comes and goes. It's intermittent. It lasts for 5 to 10 minutes. She doesn't have it anymore. It's been 3 days. It's not associated with any shortness of breath or palpitations, but more so nausea and vomiting. She has a history of hypertension, for which she's on Norvasc 5 milligrams daily. She's also smoked, so it's about 1 pack a year for 20 years. And she has a family history of heart disease as well. Her brother had a heart attack. And on exam, she looked well. She was in no distress. Her vital signs were stable. And her cardiac and respiratory exams were completely normal.
Step 1, get a commitment.
So Nancy, what do you think's going on?
Well, I think given the fact that she's very anxious and she takes lorazepam daily, I wonder if this could just be anxiety and not actually too worried about her chest pain.
So what on her presentation makes you think this is not related to her heart?
So step 2, probe for supporting evidence.
Why I don't think it's her heart? Well, in medical school, they taught us that your typical cardiac chest pain is retrosternal, like an elephant sitting on your chest, which she does not describe. It usually radiates to your jaw and to your left arm, which she also doesn't describe. So that's why, and also she has a history of anxiety, so that's why I think it's not cardiac chest pain.
Step 3, teach general rules.
So Nancy, coronary artery disease is a tough diagnosis to make, since not all patients always present with those textbook examples of that dull retrosternal chest pain radiating to the arm or the jaw, and they having associated symptoms of nausea, diaphoresis, shortness of breath. Especially, so patients can often have atypical presentations, especially women or patients with diabetes. So it's really important to keep a low threshold for evaluating patients with coronary artery disease, especially if they don't present with that textbook example. Does that kind of make sense?
Yeah, thanks.
Step 4, reinforce what was done right.
So let me give you some feedback. I think you did a great presentation. You wonderfully presented the history and gave all the pertinent details of the, in terms of the pain and associated symptoms. I really couldn't think of any other questions to ask. I think your physical exam was very focused. You asked all the pertinent positives and pertinent negatives, and I was really able to create a mental picture of the patient.
And step 5, correct mistakes.
So one thing I think you could work on, Nancy, would be your approach to chest pain in general. Often that differential diagnosis can go on and on and on, and it can become quite difficult. But really, I think it's important to rule out really those 5 risky conditions. Those could be acute coronary syndrome, pericarditis, pulmonary embolism, pneumothorax, and aortic dissection. So when you leave a patient's room, it's always a good idea to make sure that they don't have one of these conditions, because the downside can be pretty huge. So really, I think it's important to feel comfortable knowing these 5, and then to work, to arrange your investigations and diagnosis accordingly. If we miss a diagnosis of GERD, it's probably not a big deal if we miss it for a week or 2, but if we miss acute coronary syndrome, it could be a bigger deal.
Thanks, Dr. Jane, for your feedback.
All right, let's go see the patients. Hopefully that was helpful. Alrighty. So just using that as a one case example, again, it was adapted from one of the examples I saw online. Really getting a commitment, what do you think is the most likely cause of the patient's chest discomfort is how we started off. Probing for that supporting evidence. What details in our presentation made you reassured it's not her heart? And then we talked about some general rules as a third point, and just reminding her that not everyone presents with those typical textbook example features. We reinforced what was done right, giving specific examples on her history and physical exam and how it was pertinent, and then correcting her on mistakes, or really giving her some type of tool to work on, maybe looking at her approach and ruling out really the serious causes first. All right. Any of you guys used the 1-minute preceptor before, or amendment to this?
No, but I really liked it. And the second thing is, it took about 3 minutes. And I'm just wondering.
I posted
That is a really good point. It's 1 minute only for the teacher in total. And the purpose is to force the teacher to stop talking and listen to the learner. So the learner might be talking for 10 minutes, but the teacher should only be talking for 1.
Yeah,
and that's because most of us overteach, right? Most of us talk too much, and the learner should be doing 90% of the teaching or talking.
And I think, again, a way to, just to keep things short, but I think to amend it again, what was done right, what can be improved, again, amending it to really get the learner to give their own insights. All right, so we got our 5 micro skills. It's all going to be ingrained in our brains. So now we're going to do some role playing. So we're going to get into groups. So we're going to use our playing cards again. So group 1 or case 1 will be cards 1 and 2, or ace and 2. Group 2 will be cards 7 and 8. And group 3 will be cards 10 and jack. So what we'll have is that one person can be designated as the teacher, one person can be designated as the learner, and just for time, we're going to have one observer. And you'll have 10 minutes to write a script based on a case that we'll give you. It's actually in your packages. If you open your purple packages here, we have a sheet called Role Play, the 1-minute preceptor model in action. And we have case 1, 2, and 3 here. So again, in your groups of 3 to 4, 1 learner, 1 teacher, 1 or 2 observers. You'll have 10 minutes to write a skit, and you can use this sheet as a little template to guide you through the 5 micro skills. Again, feel free to use as many as you feel are relevant. And then we'll have 5 minutes for the skit, and then we can reflect how it feels from the perspective of the teacher, the learner, and the observer. You guys want to group together? So we have case 1 or group 1, ace and 2.
Does everyone have a card?
Everyone has cards?
I have someone's card.
Yeah, that's me.
Oh.
There's different scenarios. So,
Yeah.
Who's going to assign the
Yeah.
scenario?
So group 1 will be case 1 on your sheet.
Oh, sorry.
Also, they put the jack and given the case scenario.
Does anyone attend?
This is the only group you guys.
Oh, you're with us. Ooh.
So then there's an observer. Oh.
Yeah. Perfect. And you guys can choose who's the teacher, who's the learner.
Okay.
Okay, so we have to write.
Does one group want to over there? I feel like you guys are very.
Oh,
Yeah.
No, it's just we're talking about
The types of phrases, like how we're going through certain phrases.
Yeah,
That's
It wasn't
You have the. Oh, yeah.
So we have a person now that is
So let's assign the roles. So we have to assign the roles and we have to write the script.
Does that make sense?
Yeah, so we write the script. And then we're going to perform it. But yeah, I know what you do.
Yeah, exactly. So you write it together.
And then we're
Oh, so maybe you were more than me.
Well, we're gonna time you guys just because Eugene said.
Yeah.
I think it's hard. It's way to get But when you perform it, or you can find a creative way to incorporate.
But then we have partners, so maybe we should.
Oh, like 2-3 minutes for the skit, and then you go reflect.
Oh, we do this?
Yes, you'll do the skit.
Show us,
You're like-
but it's more like, we're looking for statements.
Just a practice using that as kind of, as one tool.
So we need to have a short
Skit, yeah.
Okay, so we need to.
So maybe like a bit lighter.
I think the other bit is definitely be, so presenting it for 2-3 minutes, and then just reflecting on it.
Oh, yeah, let's
Can I
just
use
do
this
something
as
else.
a script?
Oh, I guess, yeah.
I guess this is
Or
one
it
tool,
can
it's
be
not.
No, I guess not for the men. Never mind.
Yeah, I mean.
That's fine.
Yeah, 1, 2, 3.
That's okay.
We can change it, we can make it like up to 5 minutes. Let's have it more general.
I thought the guy was diabetic. That's the other guy. That's why I was speaking about this chemicalitis, because the diabetes, that's what you see most of the time.
I can, yeah, exactly why, right?
I'm happy to be a student.
Yeah, she has to show it
Okay, I'll be
So it's either pass or ride.
Yeah, that's a good point. So why don't we, I mean, it sounds like.
I think what we'll do with the rest of it is
should take, we'll say, but I'm just saying, whenever you want to say, okay.
Okay, so we've got the history.
I don't think that's what you want.
Like, I was like, or even very, like, I was thinking.
They say like one or
They've
two.
done this like 10 times before, and they say that kind of before.
So I think
So we're gonna make
like
some
more
more
like
something.
all the teacher does the 5 skills, one after the other. So that we kind of follow that.
So one person to shoot one.
So are we doing?
Would like to be the teacher.
We've all seen that.
Yeah, I know, I like this.
Minutes to prepare and 5
No, I know,
minutes.
I don't know. Yeah. Yeah, that talks is long.
I'll be taking minutes.
I like how you use that.
So the basic things, the basic thing is like what's going to be the line to get my
Yeah. Okay, I mean, so thinking about the case presentation, so
So the guy has decided.
And so I'm assuming that I'm going to, or not, like, without the idea, so like, actually get.
Miller has history.
Okay.
Just work out the chances and there's
So that's so you have to have some sort of microscopics again, I suppose, right?
Yeah, they try to set them up.
And because I'm often like,
We didn't ask that.
Right,
Yeah.
Kind of, so we just, are you okay to change it back?
Yeah, it's okay, no problem.
I think this,
But it's just something on top of it. I still have, like, I did a few notices, but a hard time using. They forget about it.
I didn't have my, I think negatives are so.
No, that's good.
I have a bias. All our patients are vascular and they have diabetes, and it's often missed in the ER, and they ask us because we're dialyzing the patient. And when we dialyze them too much ref, they suffer. Because they lack flow.
Yeah.
Yes, because it's really similar. I've seen this so often when I was in GI.
We can just say for like status like that.
And then you could have so maybe we can ask as brokers for it if it intends.
Maybe you just miss out. Yeah, or I can present it.
You know, like whatever you should do, that like makes sense again, like you.
Oh yeah, he's the diabetes.
Yeah.
And the heart attack.
That's what you say about actually.
That's great. And brokers for it, you can ask.
Yeah, so our parents is
the story, like, make you think of other diagnoses, so that she can realize by herself. So you would probe more about the gastro than probably about something else.
I mean, they can try to like give us your methods.
Okay.
I'm so excited.
Okay.
And then you can follow up and say.
Just for my could you probe about the appropriate?
No, I think it's appropriate. I think after she has to watch it, then what are some other possibilities?
we're gonna ask
And then.
and then we'll look at that.
It's just that if we want you to get to teach general rules, well, those elements could have been. Maybe it's good that you probe about what she missed so that she can kind of realize herself. And then you say,
Oh, for sure.
well, we're
Yeah.
working through how you word it.
The worst case scenario is like, you know, it's like,
Reverse was the correct need, you did ask for it. Correct mistakes, you didn't consider it enough. It's just, maybe I'm wrong, but it's just like,
No, I don't think there's a wrong way. Yeah, there's a better way of phrasing it.
yeah.
maybe not on step 3.
I'm having a hard time with micro skill 2. Like, should it lead to micro skill 3, or it can be totally like? Because isn't it better if we kind of ask the question so that the student realizes that maybe something was missing or something? If you realized it at step 1 and then lead to the teach general rule.
Like it's almost like if you do micro skill 2 twice, because she would ask, like let's say diagnosis, and she might ask, hey, how did you understand it? And then I'll give my support, and then she might ask another probing question. Right. Okay. So that alternate between. So maybe just do probing twice.
Yeah, you can do that.
So you can have 2 probing questions.
Oh, yeah, for sure.
Okay.
Yeah.
It's just that
I guess we just want to keep it, like Dr. Maddie was saying, that we don't want to talk too much. Ideally,
but if you
should
ask
talk
2 questions, the important part is not that you talk too much, but your student, you can make them talk.
Yeah, exactly, yeah.
Okay, so then the 2 questions will be the appropriate way to do it.
Yeah, and like Raquel said, if you guys think that teaching concepts like micro skills 3 doesn't fit, you can use it. Yeah, you can move things around. Whatever makes more sense. Sometimes I think 3 also changes.
Yeah.
That's how you feel.
Okay, so I did do that because I was
Is it good? Right.
Yep, very good.
Before, when I said that,
I think so. We're just kind of reminiscing about what we
What's that?
I don't like.
I never had
I don't have a
one.
good way of.
I always just
Observations
behavior.
Something like stamps.
The other thing that you can say is.
The what?
According importance to it.
Yeah.
That was more.
Yeah, like recognizing, like, or like taking into consideration, like cognition, insight, like,
I seem to remember it, and I'm notoriously bad at acronyms.
Enlarge your differential diagnosis so that you consider this as you would in
So I guess, okay, so rural.
Yeah, that's a correct reinforcement of what was done before.
You'd like to observe? Okay.
Well,
I'll be
I guess
might be the
from what you said, the history taking and the aspect will be collected appropriately. The mistake was not considered.
Yeah, not the case.
So basically, all these things are points one.
Yeah, there's a.
Because she did it on so it should be fine for history taking as the consultation.
So
we have
Like much greater than
it's just like bloody and diarrhea and emergency. So it looks like it can look like a gastroenteritis, and it don't always have this.
I'm actually reviewing the chart. She's actually
Look, some emergency something else.
Yeah,
especially lower because it's
really that's the whole condition of vegetable language disorder and suicide and things. When I actually had a history, astronomy, that's examination sheet. That did appear a bit flat after that, but it seemed fairly appropriate. She was progressed. She wasn't really engaging in the conversation, but
and also
I
to
don't think
attend
she had any hallucinations or delusions like she reported. Yeah, so maybe it was a bit off, but I just took that for what it is.
Thank you for taking so I'm not trying to clear on the
Yeah, that's right.
might be too long, because you're probably talking with.
You know, given her
maybe
many different visits, I'm thinking
when
maybe
you
this is
see that
another
a patient has a fast pension, always consider it because it can mimic a lot of the other best practices. Because that's pretty much what you
you know, I based it mostly on the previous chart reviews and other signatures I've seen previously, and
for the teach general, I thought it was
there's some related indications around the previous.
because when he did his general code, his presentation, like it was something.
Yes.
So we should say that all constants that she doesn't complete the sheet.
You know, I'm really interested in ophthalmology, to be honest with you. Maybe
And I would just love that.
I was told you guys wanted this.
Yes.
Alrighty, are we ready to wrap up, guys? We look good? Excellent. Sylvia, thumbs up?
Yes,
Ready to go?
Sally just went to
Yeah, but this is a good.
It was tough with this kid to get down
I'll
and I'll test.
Yeah.
I mean,
Renal cause.
I thought formula switch was.
I mean, for the
reading about other.
You don't realize you're doing this to your habits and by stuff.
Aneurysm.
With my students.
That you don't, you have not.
But it's true, I just emphasize what you're not talking about.
Alrighty, guys, just in the interest of time, we're going to bring some closure. Oh, sorry. Perfect. Anyone would like to volunteer to go first?
When it's
We'll
ready.
go, yeah.
Yeah.
We're ready. You guys
Yeah.
need area
Kate.
one. If it's
One.
one area.
Right.
generally.
Alrighty, so the following case, you guys can read it up.
Do you guys want chairs? Want two chairs?
Yeah.
Yeah.
We're so tired, but
You know what, there's a chair over there.
Oh, okay.
Yeah,
You need
those
to
are-
think about it because sometimes it's partial.
Okay, great.
Or the point of the church.
Alright, so we're in scenario number 1. So, we're going to hear a case presentation from Jean, about an 18-year-old woman who presented to ER after overdosing on
Nice to see you. I'm Annika. I don't know if we've worked together yet. I just saw a patient in the Emerge in the psych area. Basically, her name is Annika. She's 18 years old, just finishing high school. She apparently has had prior ER visits. I actually did a bit of a chart review. She's had about 10 for similar suicide attempts, I think, or pseudo-suicide attempts. There's been some suggestion of previous borderline personality disorder. She apparently took 60 tablets of Tylenol, still waiting toxicology. Not really sure if that's true or not. Otherwise, she was previously healthy. She's not on any medications or allergies. She lives with her parents at home, not a smoker. And on mental status exam, she did appear a bit flat, a bit hard to engage at times, but she was well dressed, well groomed. She didn't mention any problems with hallucinations or delusions. I thought her judgment seemed a bit off, but she's 18, and that's probably why I would think.
Okay, so thank you for all the detail, but maybe if you could just kind of highlight for me what exactly is going on today with that.
Well, given the chart review I did, I really do feel like this is probably just another borderline personality kind of attention-seeking behavior based on some of the previous psychiatry notes. So that's kind of what I'm thinking.
Do you have any other kind of supporting evidence to account for that?
Just the chart reviews. I'm sort of trying to. It probably took me about an hour to go through all those 10 charts. So, I felt like that was pretty strong evidence of the personality issues.
Sure, and that's a great place to start, certainly. But I just kind kind of like to highlight to you that borderline people can have true depression and complete suicide attempts. So.
Okay. Yeah, honestly, I didn't really get into sort of the depression history at all. I am interested in ophthalmology. Yes, and I was really looking at her eyes, but I'll focus more on the history. That's a good point.
Right, and you did, like you say, you spent a lot of time reviewing the charts, and that's certainly a great place to start. And I would encourage you to keep doing that in the future because there's no point in reinventing the wheel. So thank you. But again, I would encourage you to make sure that you take your own focus for yourself and structure that around the mental health in the future. Is that fair?
No, I think that's very good feedback. I would look more at the patient instead of their eyes.
Good job.
Great.
You guys stay and tell us how.
Yeah, join us.
Yeah, so you go through each of the steps and just kind of like repeat the statement that you used to elicit.
So again, the 1 minute preceptor model includes teaching and feedback. Really the second part is the feedback, but I mean, taking one way to start.
I think for skill number 1, it was just using that. Can I get a commitment from you? Being very clear. What's going on? What's your commitment? So I think that was really easy. And then I think again asking for the evidence was just what's your evidence? What are you going? What are you back?
What are you basing it on?
What I found difficult was when we got to the second side, I found it. I could just keep talking. No, that's not the point. So
you guys were you were below it though.
Yeah. Okay. And so I found that a challenge. Again, about the teaching, like I said, I could have gone on and on, but.
Yeah, I think that the main teaching point came out that I need to screen for depression. I need to sort of look at that a little bit more. So I felt like it was a very. If I was a student, it would have been a very good learning experience, and I would be.
You got the point of what.
Yeah.
It's that pearl instinctively.
The pearl, yeah.
Does the rest of the class have any comments or questions for this group? Thanks, group 1. Another group wants to volunteer. Are you guys group 2? Sure.
So this case was implanted for Melanie, even though it's a nursing case. It just happened to be.
My supervisor.
So I can read the case for you guys. So EB is a 16-year-old patient with type 1 diabetes admitted to hospital who was found by a nursing student to have a capillary blood glucose of 2.8. So the patient's stable now and they're having their teaching encounter.
Hi, Soleil.
Hi, Mina, how are you?
Good.
Everything?
Good. How about you?
No, the weather was outside is very good.
Yeah?
Yeah, I like the weather outside. By the way, I had like 16-year-old here. She's not just type 1 diabetes. I don't know. The lab called me because there's some blood was done and the emergency kit. I think told me that blood sugar is 2.8.
Wow.
And the patient looks sleepy, difficult to talk, sweating, and shivering. I'm not sure if it's tired, want to sleep. Maybe because the blood sugar is low and not too much data.
Okay. Tell me a little bit more of what you thought was going on in the situation. What do you think was going on?
Yeah, the patient looks pale, is sweating, is having difficult to talk to me, looks tired, she wants to sleep. I don't know if she was doing shopping today and she's tired now. Or maybe the blood work because of 2.8, the blood sugar.
So you did reinforce that, you did get a phone call of 2.8. So this is very common in type 1 diabetes.
Oh.
It is a bit much more concerning because the blood sugar is 2.8. Patients with very low blood sugar is very important to get in touch with your primary nurse that's taking care of the patient
as well as the doctor, and maybe even speaking to the charge nurse. Okay?
So he came to you because the blood sugar as a nurse supervisor.
And that's great. That's great. You told me that the blood sugar was great. You're aware that the blood sugar was 2.8 based on your assessment. You did a lot of assessments as far as the patient being clammy, sweating, decreased LOC. And I'm very happy that you came to me about the situation.
I'm going to follow this next time.
Okay. And I'm happy that you came to me immediately. But do remember that when you are in a situation like this, and you come across someone who is type 1 diabetic, a blood sugar of 2.8 is very concerning and low. And remember that, we can give them, a cup of orange juice with a couple of packets of more sugar in there, or we can consider doing a D50 push with the doctor being present. And that will help the patient's blood sugar go right back up. Okay?
Thank you very much.
Did you guys stay until how you felt?
I see this all the time. Just last week, I had a student who, I was taking care of a student. We had a patient who was on a dysphagic diet and was on vector-thickened fluids. So, she gave the patient thickened fluids, but wasn't thickened enough and started coughing and was at risk for aspiration. So this is done on a consistent basis for me, but when I sat down and looked at the steps, it kind of made more sense as to what I was doing. So this exercise is super, super helpful for me, and it gives me a lot more ideas and skills and tasks of implementing it appropriately and effectively. Yeah.
How did it feel as a student, Zach?
I have general rule. I work in emergency, even to the labs or yes, any critical lab result should be immediately to the scene. But here the student, I think he didn't realize that 2.8 is so low. Maybe he doesn't know that the normal range for that. So that he was thinking in other differential diagnosis like thyroid or something, and he didn't keep in mind that 2.8 is critical in patients with type 1 diabetes. Lack of experience is common in junior healthcare providers. Should be supervised all the time, and the feedback regularly and effective all the time. They need more frequent feedback.
Maybe she moved you from unconsciously incompetent to unconsciously incompetent.
And I really liked how she was very clear, using direct language.
Yeah. And I think part of it has to do with deal with your mannerisms and just being calm in situations like this. Because if your student sees, your clinical instructor, crazy and all over the place, that kind of discourages you from, doing things differently and kind of wanting to be in that situation again and working on it. So I think that plays a key role.
I think what you mentioned, Melanie, like unconsciously you're doing this, but I think it's like ACLS is so successful because there's kind of a stepwise strategic approach, and especially when you're so busy, having some type of framework to work with can be helpful.
It's very helpful. I think what you did really well too was that I think sometimes a tendency, because you don't want to hurt the learner's feelings or make them feel bad, sometimes we overcompensate and we don't really highlight sort of how important it is that they take this take home. Like 2.8, like that's what Susan, I thought you did a really good job about like sort of being respectful and not getting mad at him, but at the same time you were, something about your tone of voice was still getting the message across, like this is serious and this is how we can improve the situation next time. Like you didn't sort of say, oh, it's okay, it's not a big deal, which I think sometimes we can do if we're so afraid of hurting.
Right. She was still authoritative.
Yeah, exactly.
I agree 100% with that comment. I mean, if someone said sort of low glucose versus shopping too much, I would probably like in my brain almost not have a good response. So yeah, I agree. You need to be serious about the in the moment, and you need to obviously manage your emotions and feelings and kind of make sure you have a very professional, good response.
And just helping the learner take that step back, which you did really well.
Thanks, guys. Last group.
So scenario 3 is DH is a 42-year-old gentleman who presents to the clinic, a family medicine clinic, with a 2-day history of abdominal pain. So we have a PGY PGY1 family medicine resident who has returned to discuss the case with the supervisor.
Hi, Dr. Nancy here.
Hi, how are you, Christine?
I'm okay, I'm okay. I just saw this patient. He's a 42-year-old man. I just saw him in Emerge. The one who sent me down to see him with abdominal pain. So, you know, I got a sense of his history. So, I mean, essentially, he's been having 2 days of abdominal pain. You know, prior to that, he's never had any abdominal pain before. The only other thing that he's had is that there's been some blood in his stools. That's a fairly new thing. I'm not having nausea or vomiting. He's otherwise well, like his review systems is normal. He's not having fevers, although he's saying something superficial, but otherwise he's fine. And then in terms of his past medical history, I mean, he is a diabetic, his BMI is 35, he does have a history of peripheral arterial disease, so I think he's been seeing a vascular surgeon, but I don't think he's actually had anything done yet. But the rest of his history is actually pretty good. Again, like no abdominal conditions, no liver disease or anything like that. He's a pretty heavy smoker though. He smokes about 20 pack years. I don't know, social history, yeah, he's a litigation lawyer. He has a daughter, 5-year-old daughter, who actually just had gastro recently. And then, yeah, the rest of it, like medications-wise, he's just on, you know, the usual, some aspirin. He's on, you know, his diabetic medications. I think he's actually on insulin too. And that's it. His physical exam, I don't know, he's just sort of diffusely tender, but nothing, like no acute abdomen sign. He's not rigid, nor negatively. The rest of his exam is really
Thank you for going the same time. That was very helpful. What do you think is going on?
Oh, I was hoping you would tell me that. Okay, what do I think? Well, I don't know, his daughter has gastro, and you know, he's only 42, so I thought, well, I mean, that's very likely. Could be, I mean, I don't know, like, you know, usually I present and then you, like, usually my preceptor tells me what's going on. I would, if I had to guess, I would say gastro.
Okay. And that's a fair guess. What parts of his history or the exam made you think that he's gastro?
Well, I just thought the daughter had gastro. I mean, I don't really, and he didn't have an acute abdomen, so I just didn't, I don't think it's appendicitis or anything like that. But yeah, I think if there's like a clue in the history, like the daughter's sick, then that's probably the most likely.
Okay. If you have to think of differential diagnoses, what would you think?
Other than gastro?
So differentials.
Huh. You know, constipation. But I mean, he had bowel movements, there's blood in it, but I mean, I could guess so. Oh, I don't know, maybe I don't know, I didn't really ask that question. Infection, I don't know. Other infections.
Alright, that's okay, we'll get there. Don't worry. So what I would say is that what I was very impressed by is that you took quite a comprehensive history. You've got lots of different points in there. You covered the chief complaint, the history of the complaint. You covered his past medical history and relevant social history. You covered the medication. So you definitely did a good job of gathering the data. And that in an acute situation and going down to emerge can be difficult. So I'm definitely very impressed with that. And you were concise. You didn't take a lot of time trying to relay all that history back to me, so that's definitely good. What I would say going forward, something that might help you develop your differential diagnosis, and something that you should be doing more at your level of pain now, is to try and link all the past medical history, link the medications that the patient is on, and try to think as a result of the past medical history or other diseases that you know they have and are getting active treatment for, what else could be going on here. So try and link all the different pieces of the history. Instead of just gathering it, try and piece them together and see what the commonalities may be and what one disease may be, may put the patient at risk for, and what other pathologies they might develop as a result of it.
Yeah, I mean, I just wasn't really sure if there was really anything like specifically active. I mean, I know, yeah, he has all these vasculars, but he's not coming in with chest pain. So
no, you're right. It's not chest pain, but I'm very happy that you picked up on the vascular, because I think as a general teaching rule, what I would say is that when you're thinking about something like an acute abdomen, which is what it seems this man has, because he hasn't had these complaints before, we just said that in the history, is things that you definitely want to rule out is the appendix. You want to rule out an obstruction. You want to make sure that there's not a perforation. You want to rule out that this isn't ruptured aneurysm. And you also want to make sure, given its history especially, that this isn't colitis, ischemic colitis.
Oh, ischemic colitis.
Oh, so that's another one to think about. Okay. It's okay, we'll go back and we'll take a little bit together and then we'll develop some more plans. Good. I wasn't expecting Christine to be quite as she was, so it was a lot more to comment on.
Oh, sorry.
Which was good because it actually really made me like think about what I was going to say instead of just like, you know, one-liners, which was helpful. I think it's actually a lot harder to sort of try and give the positive feedback when you know that something that you think might be obvious is being missed. So it's hard to like step back from that and say, okay, let's not jump at the fact that how could you miss this thing with all the history, and let's figure out where they have done well and like, you know, concentrate on how they can build upon the good things and then correct the mistake, but in a supportive way. That was,
I think Melanie said had the same thoughts with the
So that was hard.
And we changed, I don't know if I'm going to do it. I think she did a good job of showing that we changed the order because it just, for the flow of things and in real life too, sometimes we feel it makes more sense to have like teach the general rules at the end.
Which was an option.
And that goes back to the flexibility of this model, where you can definitely tailor it. If you don't think one part's needed, you can take it out. So, and it really, what I liked, it felt like a conversation. I think she was able to teach so many key points, and in just a mere kind of simple one-on-one conversation.
It is hard to do it in a minute.
I was going to say, yeah. You guys were about 5 minutes. I didn't really time what the time was, but it's hard to stick to a minute, especially when something is like abdomen pain with differential as well.
And I think it might be hard in a family clinic to use this model for every single patient and every single resident they see, for every patient or resident sees. But I think finding 1 or 2 key cases a day where you can implement this model. Otherwise, you'll be there until 10 at night.
May I ask you a question?
Yeah.
Is the tool mainly some roles? I mean, she used the same tool in all your questions and discussions. You know, when I was listening to Melanie when she was trying to correct the mistakes, she changed her tone. So, which is, I don't know if that plays some roles there or not.
Well, that's an interesting point. You know, the way that you communicate and convey different things. I think, you know, being more clear and descriptive with things definitely matters. Great. Good job with that. Yeah.
So the last didactic session is kind of addressing the things that we're hoping to get to, that we've alluded to throughout our presentation, to get students who are feedback seekers. So I put up barriers the other group also outlined in terms of barriers or obstacles to giving feedback, including lack of time, fear of giving or receiving criticism, inconsistent feedback from sources, and we're focusing more on this inability to respond and lack of acceptance. So really implementing the action plan and increasing receptivity. And the importance is, in order to create the positive experience, you need to overcome the barriers. And this will increase, in turn, increase receptivity and ultimately promote feedback seeking. So we kind of constructed it as 4 stages: overcoming barriers, making the experience positive, increasing receptivity, and ultimately feedback seeking. So one of the models that I was alluding to, kind of Eugene making a segue to earlier, is the ECO model. And I really wanted to cover this because I think it's great to kind of deconstruct the feedback scenario. So this is a person-centered model taken from the counseling literature and used in multi-source feedback. So particularly if you're at a program director level, which I think many of you may find yourselves to be, and you're compiling feedback from many people and sitting down with your learner and going through that. And what you do is engage the learner as a partner in the feedback session. And I really want to focus on this exploring emotion piece, because what was interesting was what this can do when feedback is surprising, and either surprising in a positive or surprising in the negative. So when you explore the emotional reaction to the feedback and actually elicit that from the students, what they were finding was that sometimes students are surprised by positive feedback that you think is actually warranted. And in this case, it uncovers students that may lack confidence in their skills. So the real issue becomes, how do we employ strategies to build the learner's confidence so they can actually utilize this feedback, because they're so hung up on that emotional reaction. And then the other aspect of that is surprising negative feedback. So helping the learner move beyond the emotional reaction of disconfirming feedback and moving away from a person level to a task level. So addressing head-on is one way to do that. As well, clarifying content enables acceptance, and then coaching for outcomes. And these outcomes are based on a dialogue, and they address the learner's needs as well to enhance their performance. So in terms of feedback-seeking behaviors, how can we move our residents towards feedback-seeking or our learners? One is delivery of high-quality feedback, which we've talked about in many of our earlier segments. And then the other is promotion of feedback-seeking through supervisors. What is our role in this? So there are 4 central factors to encouraging residents to seek feedback. In addition to the relationships, making sure the purpose of the feedback is clear and the quality is high, and addressing the emotional responses, which can be through the ECO model. It's also this first learning place, workplace culture and climate. So this is more at an institutional level now, and where do we fit in that picture? So this diagram highlights it quite nicely. And it addresses how the relationships and the quality of feedback contribute to the perceived value of seeking feedback by the residents. So perceived value needs to outweigh perceived cost to ultimately lead to feedback seeking. And the value could be to the student being perceived as someone who does want to learn. Even if they're struggling, they're interested, they're invested, they want to take this feedback and improve. And ultimately improving their performance and patient outcomes. And the perceived cost can be fear of lowering your self-esteem or humiliation. And this is where the emotional aspect comes in. But the workplace climate and culture encapsulates all of this. And what we can do is look for or try to promote within our institutions faculty development sessions where we learn how to give feedback more effectively, but putting our money where our mouth is and really encouraging learners in their orientation and following through on this. So stating to them that feedback is going to be given frequently, it's going to be of high quality, and giving them the tools to be receptive to that feedback. So you're doing workshops to help us be better feedback givers, but also workshops to help students be better feedback receivers. So another way to, as I say, put your money where your mouth is giving the opportunity to take it away from lip service of saying that we want to make it a two-way dialogue versus a one-way flow of information to actually doing it. And Fluid et al. Highlight a formative, so kind of a formative session called the effects model, where they utilize upward feedback, where the residents actually are given an opportunity to provide feedback to the preceptors. And what I think is brilliant about this is that not only are you cultivating a culture where feedback is important and implemented and two-way, but you're creating a generation of people who are better at giving feedback than we are. So it's very twofold. The other thing in parallel that I wanted to highlight is how patient-centered medicine is in some ways very similar to learner-centered feedback and learning. And what I love about this in true developmental teaching perspective fashion is it builds on what you already know. So you've already learned communication skills in medical school of how to communicate effectively with your patients. You've learned motivational interviewing skills, and now you're applying this to the way that you're communicating with your students. So when you use elaborative feedback, you're constantly, you're beginning with open-ended questioning to the student and allowing them to kind of give you information in terms of what stage they're at and why they made the decisions that they have. You're clarifying to avoid miscommunication. Perhaps you're even checking, asking the student to repeat back what they've heard when they receive feedback to make sure you're on the same page. Using the learner-centered approach also targets the feedback to an area identified by the resident, which is so key when we draw the analogy to when we're trying to institute a behavioral change in a patient, be it smoking cessation, change of their diet, something to that effect. When you have a patient, first of all, you're assessing readiness to change, so I don't know what the equivalent would be for the student, you can kind of get a sense of it. But then you're also asking them to elicit what the barriers to change are, as it relates to them in the context of their own life. So it becomes very personal. And then you start discussing with the patient, how would you overcome these? So they become an integral part of brainstorming strategies to overcome obstacles that truly exist for them. So when you do this for the learner, it's just as effective because you're drawing a commitment, they're invested in it, and it's relevant to their context. Finally, the importance of the longitudinal relationship. So this speaks to having that time for a follow-up plan, just as is important for us to check in with our patients in the management of chronic disease. So too is it important for us to check in with our students after having feedback and allowing them time to practice the improvements to revisit it. This also strengthens the dynamic so that your feedback is deemed credible and valid. And finally, the literature does show that regular, high-quality feedback improves performance and ultimately patient outcomes, which is something that we all went into medical school to be a part of. And then this is just kind of in Dr. Maddie's fashion, trying to take it to a little bit more complicated thinking. So acknowledging that feedback is a complex process, to look at the components of feedback, learner, teacher, context, and isolation is really oversimplifying it. And some of the sociology, psychology literature talks about situated cognition, where thoughts and actions are inextricably linked to the situation in which they occur, and ecological psychology, that decision-making is a product of individuals interacting with one another and an information-rich environment. So if you take the same resident in their first year with a cantankerous staff and a busy emerge and an overnight shift, and that same person in third year in an ambulatory setting with 30 minutes per patient and a more pleasant staff, you can see that it's more than just the dynamics, it's more than just the context. It's also how that student is interacting with that context if that style is completely overwhelming. So it isn't exactly linear. That negative environment can actually compound the areas of weakness for that resident or student. Keep going to residents. So because I'm kind of the attitude, touchy-feely, we should all be nice people person, I wanted to do a stand-up, or we wanted to do a stand-up and be counted on considering the emotional reaction of the student when giving feedback. So we just have very briefly like yes and no, and if you want to go to one side, and it's heavily weighted on the other, we'll try to argue. So when giving feedback, one should always consider the emotional reaction of the student. If you could please. And I think in the interest of time, we're probably going to let people confer and then have one speaker per side.
Have you determined no or?
Place for me.
I love this. Everybody has a positive attitude. You know what, and I was like, you know what, Dr. Betty talks about from her English background, she's very direct. She'll go and know. Okay, so maybe just a couple comments from the yes side in terms of your thoughts about that.
Well, you're saying always, right?
Yeah.
Can I say I'm there but not move?
Yeah. No. So why would you, that's a good point.
It's the always.
It's the always. Okay, so what is a situation where you feel that you wouldn't be able to?
I think in a situation where it's vital that they understand, or the student understands that what they did was wrong and could have catastrophic sequelae, I think it's important to be direct and explain that your decision making here was incorrect, it could have led to a lot more, or it did lead to a lot more. Because I think if we sugarcoat those types of things, then I'm not sure if the message will be delivered.
And usually, using the eco model you presented, you may be able to confront that emotional reaction and move beyond it.
So I did have an accent like that cheers when I was 3 years old. And I think it is part of the directness, but I completely agree. It's the always. Nothing in life is ever totally black and white. And also that bell curve that I love so much, it's the bottom 1%. And I'm consciously saying the bottom. People who really shouldn't be staying in our programs because they're too dangerous and they're not going to be able to function as independent professionals, then certainly the summative moment is when you dismiss them, and they need to be dismissed, right? And I always say they need to be dismissed as soon as possible, because otherwise we're all spending a lot of time giving these people feedback that they're not picking up on. So I don't suggest we should do this kind of direct and essentially, negative conversations in a way that would either put yourself at risk or set your program up for an enormous lawsuit. But I think that sometimes you have to just be fairly truthful, direct, and curt. And it can be, I'm really sorry to be the first person to tell you this, but what's just happened here will not be acceptable ongoing for the following reasons X, Y, Z. And yes, we'll meet with you tomorrow and go over this again, something like that. Because if you know this is someone with very little insight, you could spin your wheels and you'll be back to spending 80% of your time dealing with that person, where really you have to get on and find out what happened. Rescue the situation.
So a couple comments from the yes side.
So I would 100% agree with that type of feedback. Having said that, I do feel like that in a statement like "I'm sorry" or this is going to be hard to hear is that's consideration.
Yeah, we're just
I saw your ways and I was repetitive, but then I said consider, and considering doesn't mean that you can consider it, you're going to have bad emotions, but still do it in a way that is appropriate without sugarcoating anything. So I agree with you, Jean. Totally.
Fair. Also have a responsibility, say afterwards, little bits.
Right.
So you're considering it, yes, this person might have that emotion, and how can I support him, or is there someone who can support him?
Right, to address the fallout as well of that, because sometimes it does need to be very direct and can elicit, it's not to say that we're never going to elicit negative emotional reactions, but it's what we do with that.
Sally, one last point.
Okay, just I'm considering that, always consider that, I don't agree with it now, but to some extent we should consider the emotional what it is. Especially we're talking about patient safety, patient centered now. So,
yes.
So that's, you should up to your judgment. You should go the midway to do that. The reaction, if that's negative feedback, most of the time it will be negative, but up to my roles here, or my jobs, just do it in a good way and deliver constructive feedback. I don't like to distract that person. I need to give constructive feedback. And that's my experience also, always in the emergency, especially with a junior resident or something, I get the feedback for that. Sometimes you're getting upset and you can't sleep or something, but I tell them, this is the message. You need to get it from the shift in the lead. 1, 2, 3. Let's get it in your call. But not always consider it.
Thank you for that. So you can all have a seat. Moving on. So the final message that we want to leave with you is the importance to reflect on your feedback skills. For after your feedback sessions, you should be revisiting what went well, so you continue to use this in the future, what could be changed, and implementing new strategies. And a way to do this is to get your feedback giving observed and consulting your peers and senior educators. And finally, we kind of just briefly talked about when you orient your students to receiving feedback and the culture that you've created, you might want to provide them with this resource. So it's 12 steps. It's included in our resource list on how to make the best use of feedback. So it's useful for us in terms of asking for feedback and what we do with it, and for our students. So going back to our Survey Monkey, if you could, or not a Survey Monkey, eye clicker, if you could turn them on again. And now that we've done our workshop, could you please answer how comfortable you are with giving feedback. Waiting on 2.
Oh, sorry.
That's
I turned it on.
No problem, I do that all the time. That's why. And finally.
Guys, check to see if the clip is on.
So we'll just grab. Oh, so we have some move to these. Okay. So next question, how comfortable would you be requesting feedback? And you had a pretty good comfort level, it seemed like at the beginning, more so than we expected relative to the frequency with which you're doing it. Okay, and then finally, so going back to reform, so Lola's going to talk about this. We'll collect responses. Do you feel that through our workshop you've met your personal learning objectives? So looking back at your own form, we'll collect the responses and then share and reflect on this. How we may or may have not, and this will be our transition to feedback. Great, it's good to have some dissent because we can all improve. Keep missing the final person. I don't know who it is.
Oh, it's me.
Oh, is it? Okay.
I'm trying not to.
Oh, you're not participating. Okay, because I'm waiting for 11. No problem. So that takes us back to the personal objective.
Excellent. So if you guys don't mind picking up that orange sheets again, where you put your personal pre-workshop objective. Just at the bottom we have, do you feel that your learning objective was met? And we just have a little scale and just to reflect and share. And hopefully we can use some of this material in our next 30 minutes as well.
So once you guys are done, that will transition into the feedback section.
Can I ask a question, or should I save it for when we're having the feedback discussion?
Why is your question?
Well, it's just a question, I can't remember if it was in Kristen's subject, but the concept of, you know how you're saying we want it to be sort of two-way, and one of the ways that we can do that is by sort of encouraging the upward feedback. I like how you I think that's still something that I struggle with personally as a learner, and also if I were to put myself in the position of let's say one day I was a program director, like how to encourage that upward feedback in a very, very small program where I know in our program this has been a really big issue that comes up a lot, is that learners just don't feel comfortable giving that upward feedback when it's almost impossible for it to be, let me talk about this a little bit, when it's almost impossible for it to be sort of anonymous, or even if it should be more of a dialogue, when maybe some of the other staff that they're giving the feedback to might not necessarily be as receptive to it. Like I think this is something I still really struggle with, is like giving the feedback to somebody who's more senior or more of an expert. So how to do that ourselves and how to encourage that.
I feel like modeling behavior is so important in this, where you demonstrate examples where people at the same level within the institution are giving the feedback. And I feel like it's going to take small changes over time to create the cultural shift. Because when you're dealing with a generation where medicine was very hierarchical, it is tough to flatten that hierarchy. Because if you get feedback that, like, you have to explore your own reaction to the feedback. And if that feedback is not sitting well with you, that's an opportunity to address it and to say to your student, like give your student tips on how to deliver feedback in a more professional way. Because often when it's eliciting a negative emotional reaction on our part, it's because maybe the person's still developing their feedback skills. So I feel like it's really hard to address because I just want to say giving feedback should never be punitive, but it is going to take a while to get there. Because it's so, like, I experienced that myself. Like, I tried in residency to be very direct and honest with my program director, but I felt like there was a lot of defensiveness, and I gave up eventually. So it is as much an attitude shift at a person and institution cultural level. So I feel like this is the beginning of change.
Right.
But that might be way too idealistic, so feel free to shoot it down.
No. Just to add to that, I think as the staff people, if they are able to reflect on their own, because feedback goes with self-reflection, right? And we ask our learners to self-reflect. But I think if the staff, and you could start as the first staff to do this, Christine, reflect on your own ability, your own clinical ability in front of the learner, he or she might feel more comfortable reflecting on their own and also giving you feedback. And I think it takes time to change, like anything. But I think that might make the learner feel more comfortable. And maybe giving your staff a feedback workshop.
I know, it's really interesting.
On a retreat and do that.
I'm just envisioning this like totally toxic environment where you were literally dismissed if you ever said anything that you liked.
It wasn't to that extent, and I'm not even necessarily just thinking about my program, because this kind of applies to a lot of the subspecialty programs in interwomanism. Some of them are very small, some of them have 2 trainees, some of them have, I don't know. And it just seemed to be a very common theme, and we just had our Royal College, not the accredited, but the review, and like a lot of sort of really interesting things kind of came out of that for a lot of the programs. Some of the programs were really surprised to find out that they didn't get that they're going to have like the external review coming up and all of this. So it just made me think like if I was in that program director, she's like, what could I do differently? Because I could see how this could happen to any program. And I just, I think what you said about role modeling is really good too, though, like, because, I mean, I feel like for our, I don't know, generation or whatever, this sort of, we're trying so hard to sort of change the culture of feedback. And if we role model that even for our, like, the staff who've been around for decades and decades, that maybe they'll sort of catch on and see sort of how important this is and that they're not above receiving feedback or not.
It's so interesting to me that because the point of accreditation is to help you improve. It's not just to get that credential. And it's the same thing where if we knew everything about medicine, we wouldn't need to be trainees. If the programs were doing everything perfectly, we wouldn't need these reviews. So I can't really wrap my head around this idea that, you know, it's just everybody just wants a pat on the back, but that's not the point.
I think what Annika said at one point in one of the examples was really good. You mentioned that for you what helped is when you were told by your supervisor that you were working towards a communal goal. I think if you can convey that to your learners, that I want to improve myself as well as it's improving you guys. So this is a lifelong learning exercise for me too. I don't know, I wonder if that would make a difference.
Like we're in it together, not an us versus them sort of thing.
Build more patriotic.
I really think it should be part of core days and teachings for residents, because as residents we do teach medical students and eventually become staff. So I think I'm really hopeful that there's more of that culture of improvement that we're trying to foster, and hopefully things will change.
So I think just to build on it, because obviously I'm the other end of it all. I think the role modeling, I'm just imagining, you know, both what should I be doing more, and also what would I be encouraging my peers to be doing. I think the role modeling is actually somehow having to demonstrate real work on self-improvement. I think it's very easy and almost a bit seductive for people to be reflecting and to say, oh, you know, I never did like cardiology, so I really, you know, I'm not good at reading ECGs. That's, I mean, it's reflection and it's honest, but it's not really what we're trying to model as a positive way to handle your weak areas. I mean, it ought to be, well, you know, I never really spent enough time before on ECGs, so I wasn't able to help you adequately today in the clinic, so I am going to go home tonight and watch a YouTube video, and I'll report back to you tomorrow. So, I mean, I think if the staff were role modeling that kind of active improvement of areas that they didn't even really want to learn anything more about, that would be appropriate. But I think just, you know, sort of...
You're really trying to change the way you've done things all along. Where it's like, I got my 99 and move on, instead of sitting back and saying, that 1% that not beating yourself up over it, but where did I go wrong, and reflect.
But it's the last step, it's that follow through.
Yeah.
you know, oh, I've realized, you know, I'm interfering with your learning because of my weakness. I'm committing to work on it, rather than saying, you go home and learn about ECDs and come back and tell me tomorrow.
Yeah.
It's, okay, I will go home.
And there will be later.
Both of us would.
Yeah. I mean, that, both of us is nice, but the real truth is, it's me, the faculty.
Oh, I know, but the student still needs to learn, and there's part of it that, like, self-directly learning and coming back with, but if it's just like, come back and teach me tomorrow, that doesn't work, because you cannot even tell the student if what he learned by himself is fine or not. So you need to build expertise, so I think it's, well,
Yeah, I think I'd like to leave the door open for the student to commit, but I don't think I've been in a position to force them.
oh, that's for sure.
Sorry, we need to get to feedback, but that was a great question. So would you like to debrief your team, or?
So do we do that when we think we did well?
Yeah,
Or where we did improve? I'm trying to remember how we did it now. So, I think, like.
I see it everywhere.
Google Image. It's from feedback on Google Image.
No, but
Sugarcoating.
Over commentary on.
It's from the Second World War from the UK.
Yeah.
Okay. And has it been there around for quite a while, or
Yeah,
it seems trendy?
Been around.
It's
Been around
the
since
blood
the
shirts, I
second.
don't know if you've noticed, it's found
Yeah,
in
it's
people
trendy
now.
now,
came
but originally
about,
it was in
like,
the Second World
But
War.
there is
It's just a
trend.
trend.
Because I was
All
never
these
seen that
posters in the
before.
basement or somewhere.
It's been like really trendy for like the last 5 years or so,
Yeah.
and then eventually it's making its way over across the Atlantic, and now you get keep comment everything.
Yeah. Exactly. So I thought it was really good that, because we had, like, you know, as adult learners, we had some segments that we kind of took the lead on, but it still, when we came together, still made sense and built on each other's work without being overly redundant, but still enforcing repetition. So I really like that. One of the things, and I'll continue to struggle because I love to talk, is integrating the interactive activities and making them relevant and applicable and doing them for a reason as opposed to doing them for the sake of doing them. I really struggled with that personally.
I think, yeah, for me, I think we reached Chicago. I'm happy.
You're gonna go see the sights?
Exactly. So I think the journey was as great as, you know, reaching that destination. I think putting all the project together has helped me develop my feedback skills. I think as a resident and future faculty, I really enjoyed it. I think we learned from the feedback of other presentations. I mean, in terms of using the duotangs to help organize some of our papers. You know, I think we covered a lot of the knowledge, skills, and attitudes. And, you know, I think we worked well as a great team.
Yeah, it was just to finish off our self-reflection. I thought we worked well as a team, like Rahul said. I think when we came together, our slides, even though we did do it individually and there might be some overlap, it did fit well together, and we thought that the overlap might just reiterate some of the key points. I think the interactive activity, in terms of time management, the interactive activities took a lot longer than we thought, and I think we had to rush through some of our slides, fortunately at the end, and I think that comes with experience of running workshops, and I think that probably varies. So I think the hard part for me is I'm a very structured person, and to have to be flexible with these workshops, I find hard, but I think that just comes with experience.
I second that.
Heard that.
I guess we'll start with feedback around.
I can start.
Ladies first.
That's fine.
Lots of really useful information, which was presented really, really clearly. So that was great. You had really good flow between each other, which was nice to watch. It was humorous and entertaining at times, which was nice. You were really helpful during the group activities. You were going around consistently making sure that everyone understood, which was great. What I learned is the 1-minute preceptor model. I love that, and my objective was actually to pick a go-to feedback strategy for one-to-one teaching. So it met my goals brilliantly. And I think my suggestion for change, and you've identified it already, is the timing. Because I felt really bad for Kristen, whose bit, it seemed, always got bumped or rushed. So I felt really bad for you, because you were always the person who was left making up the time. But you guys did a great job. You finished on time despite running behind schedule, so that was commendable.
we just go in a circle with that? Would you be okay with us going in a circle? Okay.
This is expensive.
Really enjoyed the workshop. Great job, guys. And the first thing when I walked in, I just loved the setup of the room, and the folders was also well organized. That was something I really liked. And again, great interactive sessions, very relevant. And just love the way you all started off with this. It really, just got us into the mode of feedback. And again, the role play for the 1 minute preceptor, I found it really helpful because I've had sessions before on 1 minute preceptor, but this has kind of really, hammered in all those 5 points, and I'm sure it's going to be very helpful. And of course, the way you interacted with us during the interactive exercises, just to see that you were all, okay, that was great. I learned about the feedback techniques. Of course, the 1 minute preceptor, it's been, I've learned much more about it now, and of course, the student-centered model, I thought it was great, and I need to go back and read about it. And just suggestions, which again, about the time, just to say that remember to just factor in more time, especially when your interactive activities involve input from others, because you can't control that. So we found it a problem in our workshop, and I know you really made good time, but just so that you are not tense and it's like, yeah. And just one thing about that's just a very small point, that the purples and reds and the pin
Dr. Bucky said the same things.
Great
so
minds
try to
the ones with green, black, or blue, those are the
green, black, or blue.
Those are the ones which are the clearest.
All right, thank you.
Oh, that's from the family point of view.
Alright, so what I like best, again, was getting to practice the 1 minute preceptor models. That was something I learned, so what I learned was the 1 minute preceptor models. Getting to practice it was really important because I'm not using it. I also learned about focusing more on learner-centered feedback, and also being more mindful of creating a culture of feedback. It's really well highlighted. Suggestion for change, it's something very specific only because it spoke to me during your presentation when you were talking about the considerations that influence the effectiveness of feedback. You really went through the message and the recipient's readiness and kind of skipped over the credibility, and that's something that being a junior staff member struggle with, and I would have liked a little bit of
shared. So what I liked best, I really liked the orange sheet that allowed us to come up with our own learning objectives, because I think in our feedback workshop, I think I kept preaching it, and yet I love that you incorporated it, because we didn't actually get your guys' learning objectives for us, so I really like that. I also really like the organization of your materials in the folder. Yeah, it's just kind of all just beautiful. Nice image. What I learned, so also the 1 minute preceptor model, again, I also really like that you you demonstrated it, and you also helped us practice it. And then in terms of suggestions for change, the only thing, this is a very minor thing actually, was just during the family feud. I think some of us forgot how family feud works, like when you have to answer individually and when you can discuss with the group. And I think there were a few pauses where we were like, oh, we're not really sure what to do. So maybe just sort of briefly giving the instructions at the very beginning to sort of cut some of that pause during the activity.
Thanks guys for running the workshop. I actually really liked the activity with the Think, Care, Share, where we talked about behaviors and feedback characteristics, because it's probably just the way I learn by narrative, and hearing people's stories really highlighted those characteristics, which made me really struggle when I did this, because I heard your presentation, Kristen, but then I was remembering this because we interacted with this. So then but I love this exercise, and I thought it was great. What I learned from this session, so I really appreciated all the different models that you presented, and because it kind of highlighted a different aspect of feedback in the different models, and there were things like the eco and the student-centered model. I've never seen the diagram, so I thought that was nice to see, because now I know it's there, just to highlight the color, also beware of the lighting. I think in combination it made it a bit harder to read when it was up there, just because the lights were dim for the movie and then it never really went back up.
Oh, okay.
Oh yes, I noticed that I think there were some time moments that the audience wanted to reflect on what you were telling us, and we like volunteered. I think people asked questions, but I kind of sensed from the audience that we wanted to talk a little bit more, discuss some of those points, but then there was so much content that it just kept moving along. So I wonder if this could be like 4 workshops, right? But just pausing in those moments to allow the audience to because I think we reflected, and just for us to kind of ask questions, or because I don't think there were too many times that we could actually ask about the material because there was so much material.
Right.
I think that would have been nice to incorporate. We're a very voluntary audience, so we would just ask the question anyway. But I feel like if we took this somewhere else, depending on the participants, they may have tons of questions or get confused in the middle, and they just wouldn't ask. So that would be my one thing.
So I just want to ask a question about that feedback specifically, because that was such a big struggle, because there were so many things we were reading, we're like, we just want we want to share this information with you. But you guys are a very engaged audience, so is it advisable to have it so well oiled, or should you have contingency slides so that you can stop, and if the conversation carries you, you can modify the content? Like, is it okay to modify the workshop as you go?
I would
Okay.
say yes.
I think it is. Yeah, because I didn't.
I would have liked it's. I know it's hard, but I would have liked you at some point to say okay, then as you wish to discuss it now, like I remember Eugene, Sylvia, and I bringing some points up, say, let's discuss it now, and then when you get to the slides, say, I told you earlier on, we still have the writing, and people, we know you organized it for us, but if it arises and it's interesting, but that's for myself. Maybe some other people are different. I like discussion. I think you like it too.
I love it.
So I actually learned
too
maybe
much.
more from a discussion with you and Eugene and then the whole group than the slide by itself.
Yeah,
so
I agree. The flexibility part of it, I think that helps the workshop along.
So the icing on the cake that I would add to that conversation is that the conversation and the discussion and the narrative is very rich and very enjoyable, especially for scholarly academics. If English is your second language, you can start to lose track of what is going on in the room. So then you have slides coming later. That will reinforce and repeat it, which is excellent. But you may also realize that you need to become a note taker, so that rather than leading the discussion or being part of the discussion, you may need to find a way to put a few of the keywords in written format somehow somewhere in the room, so that the English language second speakers or the people who weren't clued in at the beginning, and now they're trying to figure out what's this lively discussion about, to ground it with just a little bit of visual, a diagram, a few words, to help everybody else in the room stay part of it. But that's pretty sophisticated, and I think you could do it, but as you say, it's getting to a higher level.
Okay, so what I liked best and learned from in the session was the 1-minute model. So that sat very well with me, and it made me reflect on previous feedback that I had to give to different learners. And now I can have a model and almost like a step-by-step process to implement and be a little bit more comprehensive about as far as providing feedback. So that's very helpful. And I would share it with all of the presenters on the meeting as well, because it's helpful. Suggestions for change, it's just something very small and just to be time sensitive.
So I say thanks for the group. It was great workshop. There's a lot of activity. The workshop, we keeping tracking all audience for what we doing that and keeping asking what we can ask because of the role playing and trying to give some hints for us. So I appreciate that. I like the characteristic of good feedback, types of feedback. And was something I was very interesting. That's 1 minute because I'm working in emergency. And usually I'm suffering from point of time giving the feedback to the juniors. Sometimes I give tips of information. Or I ask them to stay after ending the shift, and we spend 1 hour more after ending the shift, which is sometimes it's a bit. Sometimes many years they don't like that. So 1 minute now we practice now. I think that's very good model to really good feedback. In general, it's very good. Maybe the standard of time management and to the slides. Some slides be going fast with that. I have to focus on some slides, which it looks very important. Going down with numbers of slides to get more interactive with the audience.
I don't have a lot more to say. Additional points. I thought you did a good job of building on previous presentations. The folder, use of the folders as sort of the collective feedback of the group, I think was very smart. And just the whole the interactivity I enjoyed. I actually felt like part of the richness of this presentation was actually hearing the collective experience of the group. So I think feedback is one of those things where I actually developed more confidence with my feedback skills by kind of hearing some of the similar stories from other people. So I thought that even though that it may have been cut short at times, I still take that as part of your workshop. And yes, the 1 minute preceptor I think is very valuable tool. It's funny how things that are intuitive at some level, go into writing and then get published. I should have written that.
Revenge feedback, you can publish.
Almost all I have on my green sheet has been told, so I thought of maybe giving you individual feedback because I really like getting it last week in my own workshop. So for Nancy, I thought you do active listening very well. When people talk, I really felt that you would rephrase, that you really listen to us and to the input we would give. I think you're one of the most clear and precise communicator I have seen. When you talk, it's crystal clear. Honestly, it's very good. And you did excellent use of figures to illustrate and support your points. And the reflections and feedback from Think Fair Share were really interesting, though lengthy, and probably rushed you in the end. But I think you should spend as much time as we had taken here, because this was one of the most interesting activities. Some things I would change, really minor. I would have liked you to stand while talking instead of sitting. It's not verbal, it's really minor, and I tell you you're a great communicator, but you're really lively and confident, and it would show more if you would stand up, and you did during discussions. And the other thing is your presentation slide, you use a lot of figures, and it's great. I think the laser pointer would be a good thing for you. It's not always the case, sometimes it can be a distraction, but I felt you used the mouse clicker, and it could have been useful to you. And I learned that physicians actually do change behavior based on feedback. I wasn't sure of that, but you brought it up. Kristen, you did not read through your slides, so that's really interesting. Like you were looking at the audience like 90% of the time and even more. So that was good. You're an excellent communicator too. You're exceptionally good at analyzing content and situations that happen to you. So even if you're on the spot because you didn't plan for something, you're really good at adapting to it. And you're good to argue in a subject and provide pros and cons. Nothing much to change. The only thing, if you're able to do it, but I know it's hard, and I did use my sheets too when I presented, it's just like it makes you feel more confident. I felt you didn't even need them. And you had them in your hand with your pen too, because you forget to put away your pen. Yeah. You always have the sheets in hand. It's nothing big, but it's so easy to change, and I think that you would have both hands to express yourself, and you actually use your hands because those sheets were moving. Right. You're probably going to see it in the video.
I learned from you the importance of emotion, memory, and feedback legacy and the moment to provide feedback, and I think that was one of the major points you wanted to hammer in. So.
I just wanted to say this is genetic. My mother always has a pen in her hand even when she's driving, and I'm afraid she's going to drive all day. And she visited me this weekend, and she was sitting on the couch with her purse in one hand and a pen in the other.
Rahul, your use of images and analogies is actually outstanding. I really like that. You often had like the tree in front of the forest, the ways to for transportation, that type of stuff. That's really good because if you teach novices, and you will, you're going to be able to use their prior knowledge even if they don't have a lot. So that's a really good thing. Your nonverbal communication body language is actually excellent. I have nothing to say. Very empathic as a teacher. I can't tell you exactly why, but I feel you is very empathic to what people are receiving from you. So that's probably true in your medicine practice too, I'm sure. The use of color to highlight important words in the slide was a very good use. The thing though is that good thing that you did that because some of the slides were really crowded. So there are pros and cons. So maybe if we can split some of those slides, like there are slides that had like theory and examples. You could split it too. It would be easier for us to read and follow through, but it was fine, especially because you used color. The 1 minute preceptor activity was a big hit for everybody. I think you heard it a lot. I learned from you the 5 micro skills of the 1 minute preceptor, and if there's one thing I would change, but maybe it's me too, I had a hard time understanding why it was called 1 minute preceptor until about 10 minutes. Like, so what are you doing? Like, you take 1 minute for each, and then it's 5 minutes. There was a slide of 6 minutes, 3 minutes, 1 minute. Is this the 1 minute? And then I understood it. It's so much easier to understand. And you worked great as a group, and you were good to enrich discussions and lead them. And I would have appreciated even more, but I know you were like stuck in the time management that you want to improve too, so it's not easy.
It's funny too, because we kept saying, so after lunch, what do we do? For some reason, the whole time we were planning this, we thought we had the whole day. So okay, so when we come back from lunch, and Nancy's like, it's a break, it's not lunch.
So thank you very much.
Thank you for your feedback.
Wow. I didn't know what I learned from the course. I shouldn't stand the last person. So I didn't know why you didn't choose that one. I'm just waiting now. They will use it. But
right.
So I will have general comments. I like that you create the idea which you are using the standing from the moment. So now you are as my colleague mentioned, that's 1 minute or so. That's particularly when you implement it in the real situation. For examples, that's great. I personally, to be the last person, last group to present and seeing the others, you like to be a unique and try to avoid all the, the small, I will not say that mistakes, but we'll say the comments which have been, mentioned for other groups to try to avoid them as much as we can. But as a humans, we have some these, we have these, I wouldn't say mistakes per se, but some weakness in our, presentations or workshops. So yeah, you try your best to avoid them, but still the pressures to deliver all these contents. That's 3 hours, which is difficult, but you will put us in that. It's not enough. And yeah, I think that's all what I have.
Thank you.
So those are actually our plan B if the eye clickers didn't work.
Yeah, our low-tech solution.
Well, they actually said it before you came.
Maybe that was
That's why you didn't figure it out.
Oh.
I should have told you, but they said it before you came in.
So, if you don't mind, I'm going to speak, but I'll give you 10 minutes back after lunch, so we will start at 1:10. Because there are a couple of points that I want to make. The most important is everybody should have some kind of either yellow, golden yellow, or white for yellow lana.
Where should it be?
Jesse has them. So if you didn't already get them this morning, Jesse, can you pass them around now? Because it's absolutely vital that no matter what time you leave between now and 5:10 or 5:05, that the white ones go back to Jesse if you're in a graduate program of any kind, and golden yellow ones come back to Sally. Jesse, can I get a white? So Kirsten, you need a golden yellow one. Because these are the overall course evaluations. And we had exactly the right number of white ones.
I don't think I have a white one.
Yeah, I think Nancy.
No, but I think they're all taken.
Oh, maybe one extra here. I accidentally took two.
Oh, it's okay. I have one.
No, we do. It's either. Oh, it's either way. Oh.
Yeah.
Oh, I see.
Small things that
Try
we.
B.
Try B. Oh, yeah, it's black.
She said as long as you
Oh, that's
spray.
Yeah, no, just try B.
I don't know if that makes a difference.
Helen, I just wonder, is it the right course? It says summer here, is it? I mean, this was a spring session.
Yeah, this is a summer course because
Oh.
it's after April.
Okay.
Yeah, there are only 3 sessions, fall, winter, and summer.
Oh, I
Yeah,
see.
there is no,
No spring.
well, now they call, yeah,
Well, summer A and summer B.
yeah, or sometimes this is called intercession,
Okay.
okay? It's,
Yeah.
at one time all we had was fall, spring, and summer. We didn't have winter. But now winter is acknowledged to be winter.
And spring doesn't
So, like everyone else, I mean, it was a very impressive workshop, and it's pretty hard when you're the end to really still to come through, which I thought they did in a wonderful way. I have the individual ones, which I'm not going to spend a lot of time on, except I'm standing here because there's one thing I wanted to show you. So, all of the workshops have been excellent. Now, I'm not surprised, because I take this course twice a year. I learn so much every time I take it, and the workshops are always wonderful. So I'm not surprised, but I can tell you it still makes me very proud of all of you for all the work you put into it. I liked the sense of teamwork here, right? And you can all see this now, having seen a series of workshops. We really had the sense that, you know, they were supporting each other, they were working together. They had a lot more time to do that, I know. But on the other hand, they pulled it off really well. I liked the way they had their objectives were really clear, and one person took each objective and sort of, particularly when Kirsten did it and then came back and revisited it, that was helpful. I liked the way they kept mixing up the audience with the cards. I thought that was clever. And you all know each other pretty well, but it was nice. You got to talk to everybody and work with each other. At one point that came through was a very subtle point, which is that being self-directed is not the same as do it yourself, right? That part of feedback is the facilitation. Part of learning as a self-directed learner, you still need a teacher and a facilitator to help you. So that came through well. I think 40 references is pretty impressive and wonderful. I mean, this is great. I certainly think this is a workshop, as I'm always saying, with legs. I did tweet it out. You know, I would hope by 5 o'clock today we'll have people saying, oh, it looks good. You know, writing down your names so that they can contact you. We can tweet it out again later with your Twitter handles if you want. Because that's the reason I'm taking your photographs and tweeting them, is I want other people to start to invite you to put your workshops on. I was really relieved because the promise I always want to make to people who take this course is if you take the course, you will become a more time efficient and effective teacher. So your teaching will improve, but you'll do it faster. So I think seeing the 1 minute preceptor, you can see the kind of thing that I hope you've learned that's very specific, but very practical and very useful from a course like this. I learned a lot today. There were a lot of very recent models, like Diane Delva and that whole team of Canadians, all of whom I know, but I didn't know they had a paper on feedback. And as someone said, it was kind of intuitive, but still, it's a nice model. The KISS model I hadn't seen before, so that was very helpful. I heard go past very quickly that verbal comments are more powerful than numerical returns, and I thought, yeah, that makes sense to me. So I thought that was interesting. I also liked the tweaking and the sort of the deeper approach to the 1 minute preceptor in reminding us all that the commitment level, you can gear it to the level of the learner. So then what we didn't have here, but you'll see in the slides that I have for the afternoon, there are different standard structured ways of putting learners at levels. So for instance, the rhyme model, is this an undergrad, is it an early residency, late learner, etc. But I think to just even think about refining the 1 minute preceptor that way, I thought was very powerful. What would I change? I just mentioned one, which was bring in a few of those models that help you structure your feedback. Expectations, this idea of what level is the learner at, so they can compare themselves and you can compare them. It's a telling point is experts actually are usually correct, right? The last row here is overall rating. And if I could only take one measure off this page, that's what I would take, right? Because you are expert learners. So if you say, the overall rating is here, you're probably right. If you have to give feedback, then you have to go back and say specifically, why is that your overall? But expert opinion isn't bad. It's just that it's better at the summative end of things. So it's a subtle point to be thinking about. I wondered about whether people should be reminded that it's good to take notes. Something that I tweeted out recently and got quite a lot of retweets. I think that very strongly, and I watched the Family Feud. I got confused in the Family Feud. I mean, part of my problem is I don't watch enough TV. Next month I'll start watching more TV and I'll be better at Family Feud. But one of the things I found was that these are excellent props, right? But the slide was totally different. And if you look at the slide as I did, I mean, the slide is really clear, but, and I think Sally maybe mentioned it as well, that it didn't go through our brains very well. So really what we should have been doing, we included was, when we had that slide of five positive aspects, each one of us should have looked at the slide, and as Kristen was talking, we should have written those down. Right? If we had each written down those 5 words, then when we came to play the game, we would have done it very well. Okay? Now that requires extra work on the part of the audience. I think there's another way that this could be structured, because if you look at the slide, and I meant a few minutes ago, yeah, here, it was the thumbs up slide, right?
I was wondering if I should have gone. Pay attention. We thought that this being up here would have.
Well, I'll tell you what I think. Yeah. Okay, what I think is, you could have had this slide up, but I wondered about, could you also lost the purple slide, come back on this side? Do you have any of those purple covers?
I put that.
Blocking of
Yeah.
keywords.
Yeah.
Oh, one of those.
I recycled them too.
You've already used
Yeah.
so efficient now. But what I wondered was, if you you could have had your slide there because it was in the handout, but you could have used this ready-made prop. So as the slide was in the middle, you could have either had them open and put the covers on, right? Or you, as you spoke about them, or you could have had them covered and you could have said, okay, so what makes a positive experience? Constructive, right?
And then recovered.
That's right, you could have uncovered them all.
Right, I was really struggling with that because when you're, because you don't want to discourage correct answers.
That's right.
That was so hard.
Well, but what I'm suggesting is you
that
could
would work.
have used this for your teaching, because you'd already made it and you were gonna use it. You could have uncovered them, you could have spoken to them. Then when you were finished, you could have put the covers back on. You could have gone over and done that one, end up with both of them covered, and then say Family Feud. Because I think then we would have been working, and this is the whole business around learning in context. Okay, now that I've talked about these things, if we covered them now, if we played Family Feud, we'd all do a lot better. Okay? If you go to the next room and we try and play Family Feud, you won't do as well in the next room as you will in this room because it's a different context. So to try and maximize learning and, in this case, maximize the score on the Family Feud, I would have used the same prop several times in different ways.
Just looking at the slide now, there are no numbers on the side, so I didn't know to which slides you were referring to Family Feud.
Right.
And the other thing is, the word feedback is in all of them, but those are clearer because it's only one word, so it's easy to remember.
Yeah.
The other are sentences.
Yeah.
So if you had said like, what makes a positive experience, feedback is column,
Yeah.
1, 2, 3, 4, 5, and put those words in.
Right.
Could have been
Thanks.
clearer for everyone, I think.
And as I say, they seem like minor points, but when you realize how much we struggled with that game, it means that I didn't get stuck.
I shoot at the table like, name 5, and I was like, oh man, she just told it, I'm not even able to tap. But then I looked at the other side, and Eugene is struggling. I was like, oh, I'm not that bad. I was like, do I have to give 5 or 1? 1. Okay, fine. 5 or 1, but only 1.
As I say, I was struggling with why are we all having so much trouble, and what could have been done differently by the teacher. Because, I mean, the purpose of being a teacher is to make it easy for your students.
And I was really struggling with that, so I think some more practice, I
Yeah,
really
these
do
are
like that
very
suggestion.
practical points, right?
Yeah.
It's not rocket science, and the audience is pretty smart.
Yeah, absolutely. When they were struggling, I'm like, uh-oh, we've done something here. I think Sylvia brought up a good point too, because we went through feedback characteristics, which were, I mean, there's so many, like we couldn't have like 20 things on there, so it's hard to distill that into 5 that, it's like read our minds basically.
I think the other thing was if you had, it was back to back, right? Like I know we had the gap in between, the break in between, but I wonder whether if one of the sessions could have done, there was more time between the two, so that we weren't all fixated on this one. I think you're right, Sylvia, when you said that because we've gone through it, that was kind of in our mind a little bit more, perhaps.
And if we were even more high tech, which would be the ultimate goal, is as opposed to putting them on our flip charts, if we integrated your suggestion, because there's software to do these games online. So we could have been jotting down the characteristics of feedback that you guys were identifying that was sticking in your narrative into an online software that covered up and played the game with the electronics. So it's basically making an e-technology solution to using our prompt.
The terrible truth is the best way for all of us to have got those 10 points into our brains would have been to write them down. So, you know, Kristen had said to, you know, you could even have a piece of paper for people to write it down on,
right,
and then turn over your paper and play the game.
I like it.
I think having that story, having that analogy really helps to remember things. So, you know, you may not remember that specific word, but that concept overall.
Yeah, and that's really more important.
Right.
Right? So as long as you come away generically knowing those general principles, that's what counts.
Right.
But if you're gonna have a multiple choice or a
quiz.
then you better.
You want to set your students up for success.
So now I owe you, how about I compromise 15 minutes, 1:15? And please make sure you do some color or other of one of these course evaluations.
Just curious if you guys don't mind if we make a copy of these just to reflect on our own, and we can return it to you. But if you don't want to share it, that's perfectly cool as well. You may want to write your name if you want to know after, but otherwise. Great. Oh, just for their. You got my back, I got yours. Thank you. Great, awesome.
Oh, you want this as well?
Oh, yeah, we can. Like you're doodling. Very nice. Yeah, so, thank you, sir.
But we try to go for like at least
This is what yeah. I noticed that you guys one of my students doing pediatrics and the guy from internal, no way, this is something. Are they in the master? Are they in the master or? Do we give this?
Yes, actually, I
do know that.
No, but I thought.
I didn't know they weren't here. I knew Dave was contemplating to do this, but I didn't know if he enrolled.
Now, I think he's moving here in July. I think he came for the second Easter.
Yeah.
I think he's now moving in July and finishing everything else.
Yeah, that's
and
what.
it helped him get a